starting with the case scenarios, and one by one we'll go to the details. There are many things which might be missing in the talk, which we'll be discussing on the stations, and there may be some repetition also. So don't feel shy if you want to ask anything or to clarify. So I'll just begin with the cases. These are twins, 3 months old, born at 34. This is very common scenario in our setup. Oxygen, as Dr. Vikas has pointed out, lots of nurses and we are saving lots of preterm babies. One baby was on ventilator. They presented with cold and cough, and there was history of not feeling well in one of the twins. Common scenarios. The first twin had tachypnea, saturation was good on room air, occasional bronchi. Mother wants to know what is wrong with the child. So, this is a very crowded chart, but it's a very useful one also to put in the emergency. This is a patient who presents with respiratory distress to you. So, first thing we see is the upper airway. I won't be talking about that because today the topic is wheezing child. So if there's upper ways all right, then you see the trauma. If trauma is not there, then you see the breath sounds, whether it's critical or not. So coming to this child who presented with, what is the differential? So this is a child who presents with wheezing. Once the child presents with wheezing, then you have to examine the child whether the sound is symmetrical or not. So clinical examination cannot take, no matter how many ICUs, how many gadgets we have, but still it is the matter between the ears which is more important, and your hands and your skill and your knowledge. So when you examine the chest, if the wheeze or bronchi are bilateral, then you examine the patient. If patient is febrile, then the commonest cause is still bronchiolitis, atypical pneumonia. Asthma can present with febrile illness. We are seeing lots and lots of asthma patients presenting with underlying viral illness, or there may be some underlying chronic pulmonary disease. So this is a patient with symmetrical wheeze, bilateral, where the differential would be these all things. Then comes the patient who's got asymmetrical. Wheeze is there, but it is asymmetrical. There's a difference in sounds on both sides. In this case scenario, if the patient is febrile, you will think of pneumonia, because in children, bronchopneumonia can still present with wheeze, although crepitations will be more common. But foreign body would be one thing which you should suspect. Asthma is one thing which normally should be bilateral wheeze, but occasionally the patient may have more obstruction on one side because of mucus plus. So this is a differential of a child who presents with wheeze. So what do you think this child has? 3 months old. This would be classical bronchiolitis, right? I think this is an everyday case. We see tachypnea, tachycardia, saturating well. So mother wants to know how severe that is. There are many grades of so many things. I won't be discussing too many scores or grades because practically it is not possible to remember each and every point. Just 3 things: whether the child is able to feed, whether the child has a distress, or what is the saturation. And saturation is something which everybody of us has in our emergencies, in pediatric ICUs, even in wards also. And in fact, after COVID, many parents have SPO monitors at home also. So this is something which you can do, and very easily you can make out. What do you think was the grade in this patient who is not in ICU? Will reach ICU? Yeah, absolutely. So this is a mild grade where actually treatment may not be needed. But always remember, we do not know what will happen tomorrow or day after. So whenever child of bronchiolitis comes, always write on your card danger signs explained. And in danger signs, do write feeding difficulty, lethargy, because parents may say कि हम तो डॉक्टर के पास गए थे, उन्होंने कहा कोई बात नहीं, ये ठीक हो जाएगा. Tell them कि second, third day worsening होएगी, 3, 4, 5 days same रहेगा, 6, 7th day gradually patient would start improving. So those things you should be knowing that. So this is a mild grade, nothing to be worried about. The second baby who was on ventilator is more tachypnic, saturation is 88%, bilateral bronchi in drawing. So what are the diagnostic possibilities in a child who presents with this type of scenario? So what are the causes of wheezing in children? One was the flow chart of a patient who presents with respiratory distress, where you go as per the upper airway, lower airway, then wheeze, symmetrical, asymmetrical. But what are the causes of only wheeze in children? Wheeze is nothing but what we hear on stethos bronchi. So it is a musical sound which you hear maybe during inspiration or expiration because of the obstruction of the lower thoracic airways. So we all know what wheeze and bronchi are. So causes of wheezing can be primarily divided into acute causes or chronic or recurrent causes. If it is for the first time or it is acute, it could still be asthma. We do not know, the patient may have recurrent episodes in the future, but bronchiolitis, laryngobronchitis, atypical infection, these are more common for acute wheeze. But if it is chronic, then there are two possibilities. In chronic or recurrent wheeze, there are two possibilities. One is there could be a structural abnormality. These are common things which we see sometimes in our OPD or even in ICUs also, when the patient is presented with chronic wheeze, recurrence, marked distress. Then the structural abnormality could be tracheomalacia, vascular rings, some cystic lesion, some mass. And any patient with chronic, it's always a good idea to get chest X-ray. We always get it. Good idea to get an echo also. There may be some DCM which is just presenting with chronic wheeze, or there may be underlying CHD which may not have any otherwise normal. Similarly, there are functional abnormalities. Out of these, common are reflux disease, asthma, recurrent aspiration, don't forget CF, immunodeficiency, PCD, underlying BPD. So these are 5 or 6 things you must know when the patient presents with recurrent wheeze or chronic wheeze which is not going away in a day, in a week or 2 weeks, and it is persisting, especially in a younger child. So long list of differential diagnosis, but these are only come into picture once the patient is not improving to your clinical management, which is typically acute bronchiolitis. So this patient is most likely bronchiolitis. What do you grade this patient as? This patient had saturation 88%, which improved on oxygen. Patient was otherwise feeling less, but patient had marked distress. So this comes to, I would say, if you take it severe, it is even better, because you should always err on the side of higher step, so that you don't miss anything. Although clinically it fits into moderate, and any patient who's got moderate to severe bronchiolitis needs admission. And this patient would need admission. You start with humidified oxygen, you give adrenaline, and HFNC is a boon which in detail will be taught you in workstations, because after HFNC there is hardly any bronchiolitis patient who needs ventilation. So now the parents want to know, or as a doctor we should also know, who are the patients who may go into severe bronchiolitis. A patient who coming to you for 10 months old with bronchiolitis, no underlying risk factor, you know that okay, theek ho jayega another 5-7 days. But if the baby was ex-preterm, underlying BPD, underlying heart disease, underlying cystic fibrosis, these are the things you must mention, because nowadays is a medico-legal times where the tenants are also very cautious, but we have to be extra cautious. This is to protect yourself also. You must know that there are risk factors for hospitalization, particularly children who are very young. And in your OPD only, in your emergency only, in your ICU, always see the saturation. If any baby saturation is less, that is a patient who might need hospitalization. So always mention these risk factors, and as a doctors we must also know it. So investigations for mild to mild you don't need anything, but if the patient has severe respiratory distress, or it is a chronic thing, or it is a recurrent thing, it is always a good idea to get a chest X-ray, which might just show some bilateral hyperinflation. But you are seeing more patients of bronchiolitis on OPD basis, which may not need anything at all. So these are the normal X-rays we get in bronchiolitis: increased marking, sometimes you may have upper lung collapse because of the mucus plus, heart size is normal. And these are the things because we get the flu panel, so we got lots of RSV patients this time, we got lots of adeno patients, influenza patients, but this is again not a must. For mild to moderate, this is not a must. Only in admission patients you may need antiviral. So in a moderate disease, again you will need humidified oxygen, and HFNC is the best way of giving humidified oxygen. You can give humidification, you can fix the temperature, you need to give IV fluids at times because child may not be accepting orally. Adrenaline dose is 0.5 ml per kilo, we give naps. If the patient has lots of bronchi, there is no harm in giving salbutamol naps, you can try. Although steroids and antibiotics have not much role. So since it's a wheezing infant in PICU, so let's see what happens in PICU. This is another baby who was actually our inborn baby who was discharged, and he had elder sibling who had mild cough. Baby had come to OPD to show, and because of the ex-preterm and because of the less weight, I had I was just writing on the car danger signs, and in front of me, child started having occasional apneas. And SpO2 at that time was 88 to 90%, started in emergency with oxygen. On oxygen also saturation was on the lower side. Although perfusion was normal, but baby had thrown an apneic spell. So what do you think is the severity of this patient? Yes. Any patient who shows any apnea, and younger is the baby, ex-preterm is the baby, underlying DPT is the baby, this is the baby who will be having severe bronchitis. And they, in front of you, they may throw an apnea, and so this patient actually needed intubation in the ward only, and then we was transferred to ICU for ventilatory support. Severe tachypnea, apnea, exhaustion. Once you start with HFNC, then it's all right. We'll be teaching you stations that you give 2 liters per kilo and start with FiO2. But sometimes what happens is that you go on increasing FiO2, 50, 60, 70, 80. There is no use of only increasing the FiO2 if the patient is not improving. Because higher is the FiO2, more chances are that you will not be able to manage the patient even on ventilator also. So once the FiO2 starts going more than 50 to 60%, that is the time we should start thinking about that this is the patient who might need ventilator support. So these patients sometimes become lethargic, they may show apnea, and these are the patients who will need PICU admission. So if the patient is not showing apnea, that scenario, even in severe bronchiolitis, always give a trial of NIV. NIV means either CPAP or you can give a trial of HFNC and assess. These are the patients you have to by the side of the patient. If within next 1 hour you think patient is getting stabilized, now patient is making an eye contact, activity is getting better, that is fine. But if you think that patient is not maintaining saturation, you have to go on increasing the FiO2, patient is getting more lethargic, then don't wait too much on your NIV. That is the time you should think about intubation. So in intubation, I'll be discussing next case, how details you put the patient on ventilator. How many of you have ventilators at your hospitals? Can you raise your hands? So normally we say it is the person behind the machine. So whatever board you feel comfortable is good enough. Although we use pressure control board in these. Basic principle is that you keep the rates on the lower side, keep the tidal volume slightly on the higher side, titrate the FiO2 to maintain SpO2 between 88 to 92%. Don't expect a saturation to be 97%. Don't expect carbon dioxide to be normal. When the lungs are normal, how can oxygen and CO2 be normal? Our aim is to keep the systems intact so that by the time of natural recovery, patient will become alright. So these patients, they respond really well if you, but keeping these patients on ventilator is also a big headache because these patients have a very good respiratory tract, they fight a lot. So we have to sedate them, sometimes occasionally paralyze also. And the best sedation for these patients, we give ketamine, which is a very good bronchodilator. Morphine is avoided because it can cause histamine release, we give fentanyl. But early weaning would be useful in these patients. So once your FiO2 requirement is less, by this patient needed ventilation for slightly longer, like 7 to 8 days, because RSV was also positive. Otherwise, ventilation you need is almost less than a week. So bronchiolitis is something you start with nasal bronchs to mask to HFNC to intubation. So same case may deteriorate very, very fast. As doctors, we should always know when is the time to refer these patients. We should also know when to escalate the patient. Giving just 100% oxygen for a very, very long time and intubating only once the patient is becoming unconscious may actually lead to arrest. So we have to be very, very cautious when we are managing bronchiolitis. Before coming to the next case, being a teacher, I can't stop asking questions. This is a 10-month-old who had sudden choking spell and presented with marked respiratory distress. There was a wheeze and decreased air entry on right side. What do you think has gone wrong? Excellent. So foreign body has included the middle lobe blockers. There's the atelectasis of right middle lobe, hyperinflation of. So there will be asymmetrical wheeze in this patient. This patient may present with acute, but at times these are the patients if foreign body goes a bit down, then it will stay there for a long, long time, and sometimes infection occurs and it may again precipitate. So history of choking, there may not be any fever. So that history becomes very, very important. Okay, another patient, he right from early infancy, child had stridor also, wheezing also. मगर कहते छाती बोलती रहती है, इसको कभी कभी swallowing में भी प्रॉब्लम आती है, पर अगर पोजीशन चेंज करते हैं तो चेंज हो जाती है पोजीशन. The stridor and this wheezing changes with the posture of the child, and there is difficulty in swallowing also. What do you think is? This is a barium swallow. You can see compression. So this is classical of what is seen in vascular ring. Although there are other ways also, but vascular ring can present with. So if there is persistent stridor with your wheezing, and there is some postural variation, और वो चलता रहता है, तो chronic है, then you think of atypical things also. Although clinically any cough and cold will precipitate these things. Whenever you have any underlying tracheomalacia or any even asthma also, any viral infection can precipitate, because upper airways are already narrow, lower airways are also narrow. If you see the respiratory system of a child, there are more than 250 differences. They are at handicap. So any infection can precipitate any congenital, even congenital heart disease patient may go into failure if there is underlying viral infection. So it is a recurrence or atypicality in features. When you think classically 5-7 days में bronchiolitis तो ठीक हो जाने चाहिए, but patient is not getting better, recurrence हो रही है बार बार, mix हो रहा stridor and malacia, then you think of early infancy, within first month and में शुरू कर देते हैं. हमारे पास 3-4 months पे आते हैं, continuous चलता रहता है. This is easy X-ray, although this would present in neonatal period. What is it? So H-type fistula is one thing which is very difficult to diagnose. This first type 1 is very easy to diagnose. It is a type 4 or 5 year H-type fistula, where again there will be recurrent history of aspiration. So whenever you have recurrence of symptoms and you are not able to explain on the basis of bronchiolitis, sometimes there is viral episode, sometimes it is something like that, child is not thriving well, it's a bad type of X-ray, noisy sounds, think of this thing. This is another child we commonly get in DMC milk scan, again presenting with recurrent wheezing, child is not thriving well, occasional vomiting भी होती है, घर में nebulize भी रखा हुआ है, but patient is not improving. So what is happening here? It's a classical GERD. So it's done in our nuclear scan where they give radioactivity in the milk, and if you don't treat reflux, patient's recurrence wheezing will not improve. So it's not only bronchiolitis. Bronchiolitis is the commonest, but if you have something atypically, you have recurrent episodes, or you have a patient who is not growing well, or there is some relationship with the feeds, or there is some diurnal variation, more like lying down, more at night, then think of something else. And always put stethoscope on the chest. CHDs are many times missed and patient may present with recurrent respiratory symptoms, although the commonest is still the bronchiolitis. So coming to the next case, presented a few days back, 5 years old, he presented with cough for 4 days, breathing difficulty for 2 days, and there was fever for 1 day. This patient was using inhalers at home, but not very regularly, and there was history of nebulization at home. Both parents, mother had allergic rhinitis and father was also taking inhalers. Family history of asthma was present. On examination, this was conscious but slightly irritable. Patient was tachypneic, there was audible wheeze, both inspiratory and expiratory. Saturation was very low on room air, and we started with high flow oxygen, but saturation still remained low, 90%. And otherwise, hemodynamically, child was very, very stable. So this type of patient comes to your emergency, you always start with salbutamol and always give it oxygen. So if you give 6 to 10 liters of oxygen with putting to the nebulizer mask, then very good mist is produced. Patient who is hypoxic should always be nebulized with oxygen. If you nebulize without oxygen, there is a marked VQ mismatch, and sometimes patient may deteriorate very, very fast. So always nebulize with oxygen. So this, and normal protocol is that one nebulization takes 10 to 15 minutes. So we start with salbutamol. You can start with salbutamol half a dose, and 10-15-20 मिनट लगते हैं, खत्म हुआ next दे दो, फिर next दे दो. So 3 times area, but patient was not improving. And remember, you give it normal saline, distilled water is not used. बहुत recurrent बार बार दोगे hypocalcemia हो सकता है, back of the mind you should take care of this thing. And since distress was persisting and these are the patients bronchioli, any airway problem. For that matter, any child, they because of their less humidification, they need humidified air. So emergency we have HFNC. So nowadays in patients who have got upper or lower airway problem, oxygen support is given in the form of HFNC. HFNC was started, FiO2 was increased, but somehow his saturation was not improving. It was 86 to 88%. So within next same hour, IPRA and NABs were used. I think everybody is using ipratropium, and ipratropium is very compatible with salbutamol. You can mix in the same solution. I mean, total amount has to be 3 to 5 ml. So ipravent solution was used. But make sure that you are not giving it for 24 to 48 hours. If you continue ipratropium for more than 48 hours, on third day patient would start having developing fever. You may think it is hospital-acquired infection, but it is one of the side effects of atropine-like derivatives. So 48 hours normally we give. Ipravent was started, 1 dose of steroid was given, but patient was not improving and patient was given magnesium sulfate. How many of you give magnesium sulfate? Very good, almost all. I think all severe asthma need magnesium sulfate. So 40 to 50 you can give about 25 to 75 milligram per kilo. Initially we used to give 1 dose, but nowadays 6 hourly dose can be given for 24 hours. It means you can give 4 doses in 24 hours. So slow infusion was given over 20 minutes. Remember that it can cause tachycardia, bradycardia, some muscle weakness, but majority of the times nothing happens, but you should be careful. So this patient was given magnesium sulfate. Steroids, I am adding this because there are so many steroids available. It is your just choice. If the patient is not able to take orally, then you can give methylprednisolone, you can give hydrocortisone, or if the patient is able to take, you can give oral prednisone also. Steroids are the mainstay of treatment, but unfortunately, all steroids take few hours to act. There are studies going on for nebulized steroid, but till now, it is the oral steroids which are given. If you are giving steroids for less than 5 or 7 days, there may not be any need for tapering off. But steroids should be given ideally at the end of first hour or as early as possible in any patient of acute severe asthma. So in this case, because patient, we don't have terbutaline infusion, this patient was started on IV. How many of you use IV aminophylline? So IV aminophylline, although in 12 countries they are very scared of it, but till now we have a very good experience with aminophylline because we don't have IV terbutaline available. So IV aminophylline was added. It is dissolved in dextrose. We normally start with 0.5, go up to 0.8. You can go up to 1 mg per kilo per hour as infusion. And normally we don't give bolus doses unless patient did not receive any before. But these patients should be on monitor. It does lead to tachycardia, but fortunately arrhythmias are not that common. So patient was started on IV aminophylline, but SpO2 remained somehow low, 87, 88. In fact, in this patient we checked for methemoglobin also. Why saturation is so low? But that was all right. So patient was conscious but lethargic. So started with a BiPAP. What is 16 is what? It's an IPAP. You will be taught in your station. It is called the inspiratory positive airway pressure. 6 is your EPAP, which is equivalent to CPAP or P. That was started and the FiO2 was increased. Oxygen was increased to 60 to 70%. So you cannot go beyond 60, 70%. This was the time when we thought this patient is not going to be all right without ventilatory support. Ketamine is something we start in all the patients of bronchial asthma who are not responding to usual dose. So we start with 4 microgram per kg, but you can go up to 20. It's a good sedative agent, but main advantage is that it is a very good bronchodilator. Especially patients who need ventilatory support, ketamine is a very, very good dose. So this was the time to transfer to ICU, intubate and ventilate. So what is the diagnosis of this patient who is not responding to normal? Would be, initially it used to be called status asthmaticus, but nowadays it is called acute severe asthma. So this is a life-threatening asthma, which any patient who is not responding, normally we say I'm not discussing in general the PSI. I think pulmonary score index everybody knows, but scoring is something which you'll have to remember. But although in PSI these are only three things required: respiratory rate is required, excessive use of respiratory muscles, and breathing is required. But clinically, you know, any patient who is not responding to initial few doses or is deteriorating, response would take few hours. If the patient remains even same, I would not go for ventilation. Bronchial asthma patients is a nightmare to ventilate. But if the patient is not improving but is deteriorating, then we should not wait too long. So this is life-threatening. History is very important. Now this patient, since patient did not improve, for future this patient is going to be a very, very high risk patient. So whenever patient of asthma comes, if the parents say कि नहीं जी ये पिछली बारी ICU में पहुंच गया था, या पेशेंट को इंट्यूबेट करना पड़ा था, या ये 4-5 बारी हॉस्पिटलाइज हो चुका है, right at the beginning think that this patient is going to be having difficult asthma. So that history is very, very important. And precipitating factors nowadays, this year we had so many cases of bronchial asthma which we never had for many years. I don't know whether it was because of the pollution, because of the harvesting season, but this year asthma had been really, really bad. So sometimes it may be few minutes or few hours also. So any patient who shows life-threatening asthma means patient is becoming drowsy, chest is silent. Now is the time patient is hemodynamically not very stable. Patient is not responding to your nebulization, IV bag. Bags we have already given, but hypoxemia is worsening. This is a patient who should be managed in PICU. Sensorium, of course, would be affected also. ET tube and asthma. We know that it's an airway obstruction, and endotracheal tube per se is a narrow thing which would lead to obstruction, is a difficult job. So what would be the indication of intubation and ventilation in asthma? This is a clinical decision. Sometimes CO2 is 50-60. We know that patient who is tachypneic, who is having fast respiratory rate, should have low CO2. So even normal CO2 is bad for a child who is breathing very fast. But even if CO2 is high, sometimes we say wait and watch. ठीक हो जाएगा. Asthma patient we do not intubate unless it's a clinical thing. So this is a clinical decision. There is actually no lab value. But if patient is getting exhausted and you have already given more than 60% of oxygen, hypoxemia is persisting, you need to think about intubation. Do not continue your MIU with 100% oxygen. For few minutes, 1 or 2 hours is fine. But if 8-10 hours patient is on high oxygen and patient is showing low saturation, we are waiting for the patient to go into rest. So that is very, very important that NIV failure should be diagnosed early, and if saturation is falling with high FiO2, that is the time to intubate and ventilate. Although hypoxia per se is not the sole reason, because I'll be discussing how we allow permissive hypoxemia, but if PO2, SPO2 is low on high FiO2, beyond 60 to 70% oxygen, you must think about the next step. Severe VQ mismatch kind of a. But any patient who's got altered mental status is the one where you don't even wait too long. Even if saturation is fine, but patient is getting lethargic, drowsy, not making an eye contact, that is a patient you know that CO2 is going to be very high. That patient will go into arrest if you do not intubate. So that is very, very important. And of course, in asthma, we say respiratory arrest means intubate. So intubation is not very early in asthma, but when to intubate, that step is very, very important, because waiting too long is also tricky. Early intubation has its own complication, because ultimately asthma patient becomes alright. So goals of asthma treatment basically is to, mechanical ventilation is to rest respiratory muscles, protect the airway. Majority of the complication of arrest or occurs at the time of intubation. So for intubation, we say most expert person needs to be there. We need to prepare the patient well before intubation, and for preparation, pre-oxygenate. So you must have a vein circuit or an ambu bag. Give 100% oxygen for 3 to 5 minutes. The the PO2, the SPO2 should be 100%. You can give atropine, although in this patient we had given ketamine, but other drugs which can be given are propofol. We gave acronium, or you can give Atra, although Atra can cause sometimes spasm. But rucronium advantage is the neuromuscular blocking agent, which is very short acting. You should use the endotracheal tube with the largest diameter because the endotracheal tube again can cause airway obstruction. You should use cuffed endotracheal tube. These are the complications you should be aware of, which can occur during intubation because their auto PEEP is already so high that their blood pressure is borderline. So sometimes we have to give a small bolus before you intubate. So be prepared for pneumothorax, hypoxia, hypotension. And intubation and positive pressure ventilation we know per se can cause bronchoconstriction. So the humidification of the HMEs are not preferred. We should be using humidifying on the ventilator circuit. Make sure that patient's cardiac output is well maintained. So intubation is not easy, but once you intubate, then now whenever you ventilate the patient, you must know what is the underlying lung pathophysiology or what is the lung physiology. So there are three types of lungs when the patient is intubated. Either there are normal lungs, for example, in which condition where patient would have normal lungs? Shock, meningitis, head trauma, meningoencephalitis, LGBS, snake bite poisoning, all those things are lungs are normal. Or restrictive lungs like ARDS, pulmonary edema, congestive heart failure, respiration pneumonia, bronchopneumonia, or obstructive lungs. So what is this example of? Obstructive lungs. So asthma is a classical example of obstructive lung disease. Mode you can use whatever you are convenient of. Although we use pressure control mode because it is a decelerating flow, so less risk of pneumothorax. You will control the pressure. Rate is kept on the lower side in obstructive lung disease. Why? Because we want to keep the expiratory time high. It needs a time for the air to go inside the alveoli, but it takes even longer time for the air to come out the alveoli. And if you can keep rate very slow, very fast, then the time for the air to come out of alveoli is lessened. This can lead to auto PEEP, which I will be showing you. The compliance of the alveoli is normal. Once compliance is the change in volume, change in pressure. So whatever volume you are giving to the lungs, if they reach the alveoli will have a good compliance. But the thing is that alveoli should get that air by ventilator. Yes, very good. IE ratio has to be more than 1:2, 1:3, 1:4. For that you have to decrease the rate. Now you need good inspiratory time also because airway is narrow. You need a time for the air to reach the alveoli. But you need even more time, especially specific. So 1:3, 1:4 has to be kept. Volume is kept 6 to 8 ml per kilo. Pressure target to plateau is always kept 30 to 35. TI depending upon the age of the patient we keep from 0.7 to 1.5. And ratio is always 1.3 or even more. PEEP is given initially low, sometimes high PEEP may be required if there is too much of auto PEEP, but PEEP is kept on the lower side. And try to maintain the saturation around 90%, 88 to 92%, and decelerating waveform. So this was the course of the patient in the hospital. Patient was kept on ketamine infusion. Patient was kept on fentanyl infusion. Morphine is avoided because it can release histamine, and patient was still on aminophylum infusion. At times, if the patient is fighting too much and there is a risk of pneumothorax, neuromuscular agents are required. But we don't use neuromuscular agents for very long time because these can weaken the muscles. But for 24-40 hours, sometimes it may be required. And plateau pressure is always trying to keep below 30 to 40 centimeters because they are very prone to develop pneumothorax. So that is the basic principle of ventilation in an obstructive lung disease. So this was the vitals of the patient, and this is the ETCO2 monitor which is between the endotracheal tube and the ventilator circuit. And initially patient needed very high FiO2. We had to give high PEEP because of the too much of auto PEEP, but gradually we decrease the PEEP. As long as your PCO, this pH is more than 7.2, don't worry about PCO. There are case reports where patients survive even 270 of PCO2. So PCO2 does not kill the patient unless there is a raised ICP. So this patient is 90 PO2, 64 PCO2, which is alright. So permissive hypercapnia is the word, permissive hypoxemia is the word. With bad lungs, do not expect CO2 and O2 to be normal. You have to keep O2, CO2 such a level that patient survives that period. Ultimately patient ठीक होंगे, but you don't have to cause iatrogenic damage to the lung. So this is just a ventilator showing that green part, this is a flow time graph. Green is your inspiration, yellow is your expiration. So yellow should be touching the baseline. If you see on the right side, red is the patient's breath, the yellow one is not touching the baseline, right? So what is happening? This is what is the autofill. And that is why when we have PICO rounds in the evening, we tell the residents to send the picture of the ventilator, because we can make out from the ventilatory chart that autofill is happening or not. Before the expiration reaches the baseline, there is another inspiration. So ये inspiration है, ये expiration है. Expiration हुई, अभी पूरी हुई नहीं, another inspiration. Expiration पूरी हुई नहीं, another inspiration. What will happen? Pneumothorax हो जाएगा. So that is very important. So if you get a ventilator, वो कहते हैं कि graphics में हम आपको सिर्फ एक ग्राफ देंगे. तो कौन सा ग्राफ लोगे? सिर्फ फ्लो टाइम. बाकी सारे आपको वेंटिलेटर पे दिख जाएंगे. सारे मिल जाए तो अच्छी बात है. So ultimately patient this thing improves. This is another monitor of the different patient. This is an EtCO2. EtCO2 is end-tidal carbon dioxide. Very different. This nowadays because of EtCO2 and SpO2, we are not sending samples every 1 hour blood gas. But this is a typical graph of end-tidal CO2. It should be like square. Do you see this graph? This is slightly tilted. Now this is what happens in obstruction. So this is normal EtCO2 graph. In obstruction it happens like this, and in severe obstruction we call it as a shark fin EtCO2. So from a distance you can make out that this is obstruction. You tell the person to nebulize the patient, give bronchodilator, and gradually your EtCO2 will become normal. Another thing which can be shown by this is by a flow volume loop. This is also shown on ventilator. So flow volume loop, this is inspiration, this is expiration, it should be touching the baseline. If expiration is going beyond it, or what we call as a bow sign, this is curved like this, it means there is expiratory obstruction. You give bronchodilator, nebulize, and you will see that this becomes like this. So these are all the parameters on ventilator which will tell you that obstruction is relieved or is bedded. This patient showed ribavirin on film, this flu panel, this RSV, and on film array also showed H flu. So we had started with cephaloxime. We did give antiviral ribavirin, although in ventilated patient we do give, normally we don't give. So various investigations can be done. Normally we don't get extend asthma, but patient who is on ventilator, intubated, we do get asthma because there may be lots of complication which needs to be not missed. So this was a patient after intubation, and this was a patient at the time of X-ray at the time of discharge. So you can see hyperinflated because of the pneumonia. There is some infiltration also, but there is no pneumothorax as such. So goals are to extubate the patient at the earliest, because nebulization through ventilator is not very easy to give. And once the FiO2 requirement is low, PEEP is less, patient is getting better, then over a period of time, patient should be extubated. So this patient was gradually, the settings were decreased, tidal volume was improving, and on 5th day patient was extubated and was put on HFNC, continued on DEPS. When do you transfer out of ICU? If you are needing less oxygen, not requiring extra oxygen, or the patient is already off IV aminophylline, minimum increase of breathing, that is the time you can transfer out of ICU. And ultimately this patient was discharged on 9th day on ICS. Just one or two last slides are there. If you get just one message that any child who is admitted with recurrent wheezing or having underlying asthma is admitted in your pediatric ICU, never ever discharge without inhaled corticosteroids, because this patient would come again, and mortality is increasing all over the world. Even developed countries, children are dying of asthma. Why is that? Because more and more asthma is developing all over the world. This is going to be, this is the most common cause of chronic airway disease in children, most common, and prevalence is increasing all over the world. The reliability on beta-2 agonists has increased the mortality. So this is last slide, second last slide, about that all the children who are discharged from ICU should be discharged on your combination of ICS for methanol. This is a long-acting LAPA with the inhaled corticosteroids, because it does lead to decreased reduction and hospitalization on hormone. So if they don't want to give it for months together, if there is occurring asthma after few months, whenever there is cough, patient should be given combination of steroids, plain beta 2 agonist to be given, but along with steroids or combination of ICS with formoterol. So these are latest 23 Jeeva guidelines, which shows that you should always combine low dose corticosteroids whenever you are treating asthma. Do not give alone beta 2 agonist. You should always give low dose corticosteroids along with what we call as a MAR therapy, single maintenance and reliever therapy. That is very, very important. And please remember to give an action plan to the child who is discharged with asthma. So before discharging this patient, for 2 days, patient was kept on inhaler device. We started with the inhaler device before discharging the patient. At discharge, you cannot write कि inhaler आप शुरू कर देना. You have to demonstrate yourself that child is taking inhaler normally or not. So you must stop nebulization at hospital. Before discharge, child should only be on inhalers. Then you can send the patient home and make sure that they take inhalers at home also, because otherwise क्या होता है कि लेवलिन वो लेते हैं round the clock, steroids लेते हैं SOS, sometimes there may be some confusion, sometimes they are breathing out or breathing in through the nose or through mouth. So make sure that before discharge you stop nebulization and you start with your inhalers in the hospital and then discharge the patient on inhaler. Give them this advice so that at home they must know when to reach the hospital. We should not be using any patient with asthma. So key messages are HFNC is a boon for bronchiolitis. You will see in your stations, early humidification oxygen is the treatment for bronchiolitis. You must know as doctors what are the high risk factors. And asthma key points are, if you get severe asthma in your clinic and you do not have ICU facilities, but you know that patient might need ICU, please nebulize with oxygen and then refer. Sometimes we get a call that we are sending very severe asthma. By the time we get the patient with asthma, patient is already better because you had given a dose of steroid, you had given already one Maxer, we had already started nebulization. So that is what is needed. By the time we get the patient is already having the therapy. So that is very important, and always discharge or preventive therapy. That is the main aim of treating acute severe asthma or any child who is wheezing in ICU, or you must have a list of differential diagnosis and you must give your treatment as per standard guidelines. Any questions?
I just want to add one thing. I was in UK for 2 years and I have intubated so many bronchiolitis patients. Every third child was intubated. This is because always see, if a bronchiolitis there, they take a history. They are sometimes multi-trigger wheezers. So they have to be sometimes treated like an asthma child. They might require back-to-back nebulization, methylprednisolone, HFNC, magnesium sulfate, but that was not the protocol there. They used.
Yes, absolutely. I was there in December. All the my patients of bronchiolitis invariably get intubated there. Here we are using all the nebulizations and lots of nebulization. Even ketamine has been reported to be used in 2 or 3 months old child also. There is a recent case report from me. So if there is a spasm, audible wheeze, it means there is airway obstruction. So there is no contraindication. If the patient is responding, then go ahead. But intubation is not easy in bronchiolitis. They need lots of sometimes paralyzing agents, prolonged ventilation and difficulty.
Because sometimes the guidelines say it is the humidified oxygen that has to be given. The other things don't have rule. But take its history of eczema in the child, family history, multi-trigger wheezer. So they have to be treated like asthma at times. And once you do this, you can save many children from ventilation rather than, because ventilating a bronchiolitis child itself is a nightmare.
So just for the audience, ma'am, can you just briefly account for the nebulization protocol in a wheezing child, age less than 1 year, maybe less than 6 months? We have confusions regarding 3% saline, adrenaline, and then when do we start salbutamol? Although we all know that less than 6 months there is not much role.
It was initially mentioned that less than 6 months there is no much role, but now they've seen that even a 28, 32 weeker have a bronchial muscle. So even in BPD it is being used, salbutamol. So what we do is if the child is breathing audibly, audible wheeze is there or ronchi are there, then actually we start with leveling nebulization.
Any age mark?
Normally they come after.
There is no concept of like at this age we are doing salbutamol. You can use salbutamol at any age.
You can get maximum bronchiolitis at the age of 2-3 months.
Yes.
So that is a peak period. Adrenaline advantage is that apart from the bronchial dilatation, it does cause vasoconstriction also. And in bronchiolitis, it's not the bronchoconstriction, it is the edema which is there. So adrenaline is a better anti-edema measure. It's not a, but you do give a trial of leveling.
So we should start with the
Even nowadays, the even concept of adrenaline is going away.
okay.
We have to use mainly salbutamol, liver salbutamol.
So
The
3 months
concept of
wheezing
adrenaline
infant.
it was there few years back, but now it's not there.
So 3 months wheezing infant. Just to clarify,
Salbutamol.
saturation 88%. Start with salbutamol.
Use adrenaline only if you have upper airway obstruction.
And 3% saline.
3% saline, if there are a lot of secretions, again, if you see the bronchiolitis treatment as a Cochrane review, there is no role of 3%
Yes.
nebulization also. There is no role of any mucolytic agent. Only and only HFNC role has come up. Heated, humidified oxygenation, that's the one thing. Yes, your nebulization makes a difference. And your steroids sometimes, because as Dr. Mehak said, there is a multi-trigger wheeze, it's not a bronchiolitis. So, but considering two things, adrenaline and levosalbutamol, it's only levosalbutamol.
About 3%, actually it's quite irritant. We for new scooter we are using 3%. Sometimes if you're using 3% in an older child, especially 9 months, 10 months, thinking that it is bronchiolitis, it may actually worsen your cough symptoms. But in a very young child, again, although Cochrane does not show, we are not using routinely 3%. But
3% is
has been mentioned in
used
IIT
in
protocols.
conditions where you have diagnosed the condition of mucociliary dyskinesia. So in cases of mucociliary dyskinesia, now because of the advent of a lot of genetic workups are available, we are diagnosing more and more cases of ciliary dyskinesia, cystic fibrosis. In these cases where you have the basic pathology of thick viscid secretions, lack of ciliary function, where you should use 3%.
Lots of wet cough and other situations.
So I think levosalbutamol, steroids.
Just to, although I think we all know the answer, but oral salbutamol versus inhaled nebulized salbutamol only in a child who is not comfortable with nebulizations, because it's a very practical scenario in OPD. You have 3, 4, 5 months old kids where nebulization doing by parents is not sometimes easy. I mean, of course, nebulizations should be the first answer, whether done in hospital or, but any role of oral salbutamol if nebulization is not possible.
If that is not possible, child is maintaining saturation, and there is a family history as we call as API, asthma predictive index, history of atopy, or there has been a cough and cold in the family also. So these are available. Only thing is side effects, the tachycardia and all those things, and even reflux, because leveling does decrease the sphincter tone, the gastric esophageal sphincter tone. So sometimes, and same for tracheoblasia also. So if it is not bronchospasm and you are giving aspirin, sometimes it may worsen, especially in case of reflux and case of tracheoblasia, where it may worsen the cough.
Even nowadays, silent nebulizers are available. These are handheld nebulizers. They don't cause any noise. Only thing is they are a bit costlier and they have a huge maintenance because their life is not that long. We will show you in the workstation that the little nebulizer is available there. They give you a lot of meshes also, along with 30 meshes. So that costs the patient around 7,000-10,000 rupees. But that it doesn't make noise, so you can use it in any baby, hardly causing discomfort.
But otherwise, now there is no age for pumping it also. In case you want to read the mask with the spaces.
These patients who are not comfortable with nebulizing.
Why not? Why not?
See, you have to keep on trying. Main problem with the patient is the noise and putting anything on the mouth.
Yes.
And half of kit is half of kit के अलावा और बहुत कंपनीज की किट्स आती हैं जो half of kit से 10 times better है. So we have to get evolved out of. Half of kit एक मान लो 3 महीने बच्चे को लटा के दोगे, उसका वैल्व खुला ही रहता है, बंद नहीं होता.
वो भी नहीं करता.
So that becomes useless. So इसकी जगह ट्रांसपेसर आता है. यूज ट्रांसपेसर भी लिक्विड पे आता है. लिक्विड का या मैक्लोराइड का किसका आता है? वो बहुत ही अच्छा है. वो उसको देखना कभी आप. That has उसमें सारा चीजें फंडे खत्म कर दी. So आप जब भी कोई एक स्पेसर यूज करते हो, ऑलवेज यूज स्पेसर विद फ्रेश माउथ पैड. डोंट यूज स्पेसर विद प्लास्टिक पैड. वो खुलता ही नहीं. कभी आप खुद यूज करके देखो, आधे टाइम खुलता, आधे टाइम एक बार पेशेंट ने जोर से फूंक मारी, अगर एक्सहेल उसे अंदर करके सारी दवाई उड़ जाएगी, उसके बाद कुछ नहीं मिलना. So we have to be very intelligent when we using these things. They are very effective devices. But problem क्या है? Because कुछ कंपनीज का जो पहले से अवेलेबल है सामान वो इतना अच्छा है नहीं, तो वो इसलिए शायद बहुत बार वो फेलियर ट्रीटमेंट भी लगता है. spacer has such no different role in it. Only thing is you have to make it handy so that it can put in a bag and all.
We have certain devices during
वो हम evening में आपको
बहुत
WhatsApp
अगर
में ये show
छोटा है ना, छोटा है and you are rebreathing, then it is not very useful. It has to be more. So पहले आया था कि जितना छोटा उतना better है, but it has to be covering your tidal volume, and then 3 to 4 times your tidal volume, depending on the size of child. Very small is as good as not using it.
Madam, GERD and CMPA. CMPA is usually present as respiratory infection.
CMP again is a very, it's not uncommon entity. Normally it presents with severe colic in the baby initially. Sometimes it presents with skin rash, and 20 to 30% patient may just present with cough also. But reflux reflux primarily is more common in children who are at the time of sleeping, night time. Cough and what we call as Sandiver syndrome. Whenever you give a feed, it tries to extend the neck. Whereas that is why one of the things why we recommend exclusive breastfeeding is that CMP is becoming more common. But just isolated wheezing may not be that common with cow's milk. There are other things also which would be there in cow's milk.
So if you are having recurrent wheezing, then we would think get IgE levels done, get eosinophil levels done. That will give you a clue that this probably patient is a small child, where otherwise the levels are not that common. That child has high IgE levels, high eosinophil levels. Think about sleep. This is one thing which you can do. Now the even tests are
CMP test is also visible.
CMP tests are available. You can get this test.
I think we'll go to the next session. And I really thank Sunil ma'am for the amazing talk today. A small token of love to ma'am. Thank you, ma'am. It was a really nice talk. And I think everybody was looking forward to wheezing in children.
Now for the second talk, like ma'am has said that this time we have got so many patients with wheezing, so many cases of asthma. This time we have got so many patients with empyema also. So that's why considering the importance of this topic and the complications associated with this, and particularly the morbidities and long-term treatment required for managing the case of empyema, we have kept this topic. So I invite Dr. Mehak for empyema in children. Dr. Mehak is trained in the UK, and before that she has got her pediatric intensive care training from Apollo Delhi, and she is now working in Clio Mother and Child Institute. And I think you know her very well for all her work in pediatric intensive care and her work in particularly for children, where she is looking after all the orphanages of Ludhiana. Any child who gets sick in anywhere in Ludhiana who has nobody to take care of, they come to Dr. Mehak and she takes care for them. So, I'll give the microphone.
So I think we have a hall full now. So we're going to talk about empyema. So I think in last 2 months we've got about 15 cases of empyema this time, and all started with a small pneumonia, and they have progressed within 24 to 48 hours to a very severe pneumonia. Now coming to, I'm going to start with the case. So this child, 1.5 years old, male child, was brought with fever, cough and cold since 5 days and worsening distress since 2 days. He was admitted in Jalandhar and chest X-ray showed worsening, so was referred to Clio. On admission, as you can see, the child was quite tachypnic, although he was maintaining saturation, and there was reduced air entry on the left lung. So this was the X-ray for that child. Now, how many of you are very confident in saying that this child has a pneumonia, an empyema, or an effusion? You can raise your hand, whoever is confident that we know the pathophysiology of the child. So on the basis of X-ray, yes. So this is really not helpful at times, and this is a common scenario when we get this kind of X-ray and we are confused whether we should go ahead with a chest tube, whether we should manage as a case of pneumonia, or we are dealing with something else. Now let's do a lung ultrasound of this child, and you can see here. So I'm going to show you a lot of septations here. Can you see the septations in this? diagnosis. So lot of septations here, and this is the diaphragm, this is the lung, and this all black is the fluid, and the septations in that is the empyema. Now we put in a chest tube. So when I saw this X-ray and a lung ultrasound, I was pretty confident that I'm dealing with something which is a fluid in the lung, and I put in a chest tube, and this is basically after the chest tube. So we drained pus in this child. Now I'm going to talk about empyema, and I'm going to cover everything about empyema, including the diagnosis, the clinical picture, and the treatment. Now, how do you differentiate? When you get a simple fluid, it's a parapneumonic effusion, right? There is no pus in that. But when you have an empyema, you actually get a lot of pus. So there is pleural fluid, and space contains some 0.3 ml per kg of pleural fluid, and normally it is filtered. But an imbalance causes a lot of inflammation. Now, what does the pleural fluid have? A few cells, very low concentration of protein, and LDH, which is usually less than 1000. The glucose is normal and the pH is normal. So mind it, when you do, like as a person like me, if you have some amount of pleural fluid in me, if you take a sample and you send these investigations, you will get normal pH, normal glucose, and very low amount of protein. But when the disease process starts, this entire pleural fluid pathophysiology changes. Now, what first happens is an exudative phase. From the transudate, we go to an exudative phase, where a clear fluid with some normal glucose, normal pH, but a low cellular count will start appearing. Next is fibrinopurulent. This is what is happening. The bacteria invades the cells, the debris, everything, they mix up to make a fibrinopurulent fluid, and this pleural fluid will have now low pH, high LDH, low sugar, and high WBC count, maybe sometimes to the tune of 10,000 or something like that. Now this pneumonia is getting complicated. And last stage is the worst stage, where you have organizing empyema, where you get lot of fibrin strands, fibroblasts, and sometimes you put in a chest tube, kuch bhi bahar nahi aa raha, nothing is coming out. That is the time when the pneumonia or the empyema is actually organized. Here you might require something more than a chest tube, and this is the phase you actually go for a surgical orthobiopsy. Now, how will you differentiate? Now, this is all technical, no relation to clinical practice, but when you get an exudate, the protein concentration is more than 0.5. The pleural fluid LDH divided by the serum LDH ratio is more than 0.6, and the pleural fluid LDH actually increases. So the LDH is a very good marker in the pleural fluid, which explains that the child is becoming an exudate. Now, transudates, we all know, we have dengue, we have nephrotics, we have congestive heart failure, liver failure, they produce a transudate fluid. But exudates are common in pleural infection, and malignancy is really uncommon in pediatrics. So unilateral is mostly a pneumonia. The rest all congestive heart failure, liver failure, kidney failure, you have bilateral pleural effusion. So unilateral should be considered like we are dealing with probably an infection. The TB can be both, unilateral and bilateral. Now coming to the microorganisms, now this is very, very important. With the advent of giving lot of antibiotics, the MRSA is coming on the top. Now the latest Indian review has shown that 37% of the patients with empyema, they grow MRSA. So community acquired MRSA is now 37%, and when you get an empyema case, you should think about MRSA. Streptococcus remains at the top, but yes, with this advent of the vaccination, it has actually reduced in many cases. Very rare organisms, you should always think about some anaerobes, Mycobacterium, H. influenza, Streptococcus, and rarely Mycoplasma should be kept in mind when we are dealing with the empyema. Now, normally what will happen? A child has come. The mother says 4-5 दिन से बुखार है, chest में pain हो रहा है, abdominal pain हो रहा है. Just auscultate the lung at that point of time. You might get, although there may be no cough in this case, you might hardly find, there are certain empyema where the mother says there is no cough, but there are a lot of chest findings. So auscultate this child. You might have a reduced air entry, you might have bronchial breathing, dullness to percussion, and every child get a chest X-ray done, and this child, any child with pneumonia or effusion should be admitted to the hospital. Any child with effusion should be admitted to the hospital. And if the child is unwell, a pneumonia has got admitted, after 48 hours you started some antibiotic, the child is not improving, always do your scans and look for any development, because nowadays within 24 to 48 hours there is a rapid onset of developing effusions and empyema. Now imaging. Now as I said, the chest radiograph, all of you agreed that something more beyond a chest radiograph. None of us were really confident कि भाई ये तो अब final है, ये तो pneumonia है या empyema है. Now in the X-ray, what you find is the obliteration of the costophrenic angle. Everybody knows this, but and sometimes you get a mediastinal shift when you have a large empyema. But very important, you cannot know. Can anybody say that this is pleural thickening or is this a parenchymal disease? No. It is very difficult in an X-ray. You can't differentiate between a transudate, exudate or an empyema. And less than 5 ml, an ultrasound can pick, which cannot be picked by the X-ray, and because the whole thing is mixed with the lower lobe consolidation. Now, focus answer, ultrasound gives a lot of answers in this situation, and I said if you don't do it, get it done from a radiologist. But it is more sensitive than X-ray, picking up very small effusions up to 5 ml. You can differentiate between transudate, exudate and empyema, and real-time monitoring can be done. You can monitor this patient every hour, you can monitor this patient every day, that is my empyema draining or something like that. Of course, no radiation exposure. Now, I'm looking at this. This is the normal where you have a lung floating sign. It's called the jellyfish sign. This is the lung ultrasound, this is the diaphragm and the liver, and this lung is floating in this black fluid. This is pleural effusion. When you see such kind of effusion, you definitely have to drain it. Even small effusions can be picked by the lung ultrasound, but you can see that it has got very good sensitivity and specificity, and even you can detect the volume of the fluid in the adults, but not in pediatrics, and very small effusions can be detected using lung ultrasound. So I would really recommend that you all get this done. And second, very important is, look at this. This looks like a transudate. There's a black fluid. There's nothing in the fluid. It's completely black. Now look here. You've got a lot of septations. So if you're sending to a radiologist, you can go scan, see yourself. If you get these kind of septations, you're looking for loculated pleural effusion. Look here, the stars, like starry sky appearance, the small stars. And this is, can anybody switch off the light? This is basically the hemothorax. And the last one, where you can see here, is basically you get a lot of septations. This is empyema. So it really helps you. Within the first go, you can find out what I need to do next. Of course, if you have an empyema, you can't sit on it. You can't say, okay, I will not put a chest tube, let's wait and watch. If you see this kind of empyema, you have to go straight ahead, put in a chest tube in this patient. Now look at this child. This left is, we have an 11-year-old pulmonary cough, and we didn't do anything with this patient. But this was a patient with pseudomonas, basically pneumonia, and you can see lot of septations here, and then we had to put in a very thick chest tube to remove this empyema. This was pseudomonas. So CT chest. Now CT chest is not routinely recommended, but yes, when you don't have an answers from the first two modalities, it comes to your rescue. The beauty of CT scan is, many a times you see pleural thickening, you see a lot of pleural thickening, and you cannot differentiate pleural thickening, pleural fluid in a scan. So this comes to the rescue, because you can differentiate the pleural thickening, the pleural fluid, the consolidations, and lot of necrotizing pneumonia can be seen in the chest, the CT chest. And very important, you get to see the entire, like if you're looking for a tubercular etiology, you're looking for a mediastinal mass, you're looking for something else. The CT scan will give you the entire picture of the chest rather than the lung ultrasound or the X-ray, which gives you a limited information. So CT chest should be reserved for those patients whom you feel that you need to do more and you need more information. Now, that's what I wanted to tell. Now, this is the BTS guidelines. So I'm just going to say about a few BTS guidelines which have come in 2023 and 24. So, radiographs, they should be AP or PA. The ultrasound should be used to confirm the presence of the pleural fluid, and ultrasound should be used while putting in a chest tube. And CT scans should not be performed routinely. So, this is the latest guidelines. And let's go ahead with this case. So the child, first thing you have to perform is a history and physical examination. And trust me, there's no better, in OPD, just by auscultation, you will find out this child requires something else. Now, once you have done a chest x-ray and a USG, so you just did an imaging and a USG, you find out, can I aspirate this fluid? So when I said, you saw my first lung ultrasound, there were a lot of septations, and yes, I said yes, I can aspirate this fluid. Now, once I perform the pleural tap, what all will you send? Everybody. So, pH, cytology, sugar, protein, gram stain, if you're suspecting TB, ZN stain, culture sensitivity. Now, this is very important. This is something, new for me also. But you have to send both the pus as well as put it in the bacterial bottles. Put it in the blood culture bottles and send, because it has actually shown to increase the yield of the organism you are treating. And of course your blood tests, which will help you, the CRP, CBC, which will help you, go ahead with the next. Next is once your cause is found. So you've done all these tests, so suppose your gram stain is positive, or your ZN stain is positive, or you have a neutrophilic predominance with high LDH, you know you're dealing with an empyema. So once you know the cause, you treat the cause. But once you are not sure about the cause, is sometimes you see chylothorax, you see other things, you don't know what the fluid is and you're not confident, get a CT scan done, or the lung biopsy or other blood tests. You can see so many problems which create pleural effusion. Now this is very important, and just have a look at this. Now you have, suppose a child has come, you've not seen a fluid, but that is not enough fluid. You don't know, you're not very confident whether I should put in a chest tube or not. In that scenario, just do a diagnostic tap. Now this is first, and you're not, and suppose you've got pus, aapne kuch nahi karna, that is it. You know there is empyema. Suppose you get a hemorrhagic fluid, you get a fluid which is not pus, and now you're not confident whether I should go ahead and put in a chest tube in this patient or not. First thing you do is pleural fluid pH. So pH actually we've been doing since last 10-15 years. It's very, very helpful. So if it is less than 2 per 7.2, put in a chest tube. There's no second questions about it. But suppose if it is 7.2 to 7.39, what you need to do is perform a LDH. So the LDH will tell you the answers, and as I said, the pleural fluid LDH increases when you have an empyema. So more than 900, go ahead, put in chest tube. Less than 900, you can just monitor this child. Maybe you do serial ultrasounds or serial x-rays to find out what is happening. But if the pH is more than 7.4, there is very low risk. Probably this is tubercular. Tuberculosis causes pH more than 7.4. Probably this or maybe normal fluid. So this might not increase very rapidly, so you might wait and watch in this situation. But suppose your pH is more than 7.4 and you're seeing septations like this, but don't go ahead. Like you have to put in a chest tube if you see certain septations. But yes, it is rarely such scenario. You always get a pH less than 7.2 in such situations. And one more modality which has come up now is do a glucose of that sample. Suppose you don't have an EBG machine and you're struggling with that, you don't know whether I should put in a chest tube in this patient or not, just do a blood glucose sample. If it is less than 72, this is a bacterial empyema and you have to put in a chest tube. So for this value is for those who do not have an ABG machine. LDH and pleural fluid glucose will help you assess whether you should put in a chest tube or not. So the same thing, and more than 7.54 is not much indication. 7.2 to 7.4, you do a LDH, you do a blood glucose, and you see that if it is it's less than 72, go ahead and put in a chest tube. When it's less than 7.2, you put in a chest tube. So these are the normal tests we all know. We go ahead and do it when we have a case of empyema. Blood cultures do help. So do send blood cultures. They are positive in about 7 to 23% of the patients. Don't leave the blood cultures when you have a sick child. Now, pleural fluid analysis, the latest is that you have to take at least 25 ml of sample. So just don't send 5 ml, 10 ml or 7 ml. And the volumes of about 5 to 10 ml or that pus or the fluid should be sent in the blood culture bottles. And this blood culture growth will actually help you heal the bacteria. And next is that if you have suspect tuberculosis, you will have a lymphocytosis-like situation. Now, ADA is not a very good marker. Biomarkers are not routinely indicated, but in certain like high prevalent areas where tuberculosis is rampant, ADA might help, but the diagnostic is ZN stain and culture sensitivity. Do send AFB cultures. They are very लगता है 6 हफ्ते, but it really helps at times. So CBNAT has very poor sensitivity and very low yield, and that's the problem with the pleural fluid analysis in tuberculosis. Now intercostal vein. Now latest, the first thing is you put a small bore. Mainly we put a 12 French, 14 French intercostal vein. The larger bore is not really useful at times, and you can do flushing. If they get obstructed, you can do flushing and serial images again to confirm whether your tube is draining or not. Now, antibiotic cover. So very important. And as my first slide said, you have to cover strep, you have to cover MRSA. So either the first you use maybe basically piperacillin tazobactam, which cover bit of anaerobes and strep, plus vancomycin, which covers MRSA. So that is very important. But there are certain pneumonias and certain points in certain children where we are suspecting beta-lactamase organisms. You should add meropenem, especially in a child who has a history of previous hospitalization or other illnesses. And avoid aminoglycosides, they get inactivated in the empyema, not much role. And no role of intrapleural instillation of antibiotics, and mind that the duration has to be decided very judiciously. It has to be 4 to 6 weeks. The empyemas take a long time, and 2 weeks at least from the day of the defervescence of the fever. And of course, you take the help of your clinical and the imaging markers to find out how your empyema is dealing with. So this was the pus we drained. So about 200 ml pus came out from this. So once you see this pus, you don't have to perform any pleural fluid pH. This is not for this. This is just send it for gram stain and culture, and you will get the answers. Culture both the pus culture as well as the blood culture bottle. So this was, see, look at this patient. So this was the septations, and once I put in a chest tube, you can see the entire fluid almost has gone from this patient. So the patient started feeling better after the this thing. So antibiotics for this patient, pus culture grew MRSA, antibiotics given for 14 days and removed, drain was removed after 7 days. Coming to my second case, 3-year-old male child, fever 7 days, right-sided chest pain, breathing difficulty, and you can see there was decreased air entry on the right. So this child was given IV antibiotics from 3 days from a local doctor, and then was referred because the child was not improving. And you can see the x-rays. Again, we need more information. Just on the basis of x-rays, we cannot say whether this is empyema or not. And yeah. So once you do the ultrasound in this case, see, again there is honeycombing, lot of septations in this child. So it really helped us know that we are dealing with a empyema in this situation. So this honeycombing helped, but we put in a chest tube in this. So but unfortunately, after 48 hours, fever was the same, the distress was the same, child was the same, the parents were panicky, what is happening? Our child is not improving despite. And see the x-rays. This is the x-ray with the chest tube, and this is the x-ray without the chest tube. No improvement, nothing has drained, and actually the pus was not draining much in this case. So here comes the next step, that is beyond antibiotics, beyond chest pain, what can we do next for this patient. And once we put a chest tube, which is about a small bore chest tube, review after 48 hours. Now, if your child shows poor clinical response, persistent of the X-ray shadowing or the lung ultrasound findings, worsening of the inflammatory markers, what you need to do is next is look for maybe one pleural installation of fibrinolytics. The other thing you can do is, if the child is stable, you can perform a surgical option in this case. Now, I'll go ahead with both the options. Now, what we generally use is urokinase, or you use a TPA with dornase, which is really not much. But you have to choose this judiciously at the bedside. So we'll go ahead with what all. But these are the two options you have. अगर आपका patient 48-72 hours के बाद not improving, everything is the same, clinical condition is worsening, this chest tube is not going to help. We need the next step in this case. Now, coming to the intrapleural fibrinolytic therapy, now the recommendation is the TPA plus dornase, but it is quite expensive. But in a patient where you have not much bleeding, you can give urokinase. Urokinase is still the best in children. It's not very expensive and it can be given as an intrafibrinolytic therapy in the chest tube. You put this in the chest tube and you will see that the septations are breaking down. And streptokinase is almost not, there are a lot of trials which do not support streptokinase, and now they do not recommend streptokinase because they have shown no reduction in the length of stay, mortality or surgical intervention in this case. Now, this was a very good paper, and this basically said that you have, once you use TPA and you get reduction of the X-ray opacity, reduction in the length of stay and reduction in the surgical options. So urokinase is fibrinolytic and dornase is mucolytic. So, but it doesn't make much of a difference in case of, it may not always prevent you from a surgery. Now, streptokinase, as I said, is out. It's not much useful, and this is how you can, if you have a bleeding child, you can also put saline. You don't have to put always a fibrinolytic agent. If the child has a bleeding tendency, you can put about 20 to 30 ml of 0.9% saline through a stopcock and three-way tap, and it is directed to the chest vein, and then you allow the free drainage. So this might help. Suppose your chest tube is not working, it's not functioning, and it's been 24 hours, nothing is draining in, but you still see a lot of pus there. You can try a saline flush, but if not, you can put intrapleural fibrinolytics, and usually we close it for about 1 to 4 hours is the time where you can put this 10 mg of alteplase or 5 mg of dornase, and you put this in the three-way tap, and then you close it. So you use it twice daily for 3 days. And this is the dose for the urokinase. So less than 1 year is 10,000 units in 10 ml of 0.9% saline twice daily for 3 days. And more than 1 year it is 40,000 units in 40 ml of sodium chloride and twice daily for 3 days. The duration is 3 days, but you can extend to 5 days if you're showing a good response. And very important is the bleeding tendency. Sometimes you get this pleural hemorrhage, hypersensitivity reaction, and the blood staining of the. So you can try this if you are stuck with your chest tube and you see that the child is not improving with your chest tube. And in this case, we actually gave urokinase for 3 days and we drained about 1.5 liters of pus. The fluid culture blew MRSA, and now after this drainage of pus, you can see that the child has actually improved, and this child was discharged by the day 14, and this you can see that the entire pus has gone from this cavity. Now coming to this another child, 2-year-old from Mullapur, very nicely managed. This child was already given antibiotics on high flow oxygen, but his condition was worsening. So desaturation up to 85% and extreme irritability, and this is the X-ray. It's really bad. So this was the child came in a very poor condition. And this is on a CPAP machine, and you can, the voice is not there, but this child had significant stridor and a lot of audible sounds. And again, look at this X-ray, ultrasound. I think everybody can know the ultrasound now. What can we see? Yes, lot of septations, honeycombing septations. So I have put in a chest tube, and you can see the chest tube. This picture is not very good, but there's a chest tube inside, and this child had high-grade fever and distress persisted. So again, knock, that after 2 days, your child is still not improving after putting in your chest tube. Now look at this. This empyema was not improving after 2 days of the chest tube, and since we've been scanning since long, there were a lot of septations. We went ahead with the surgical intervention in this case. This because we didn't do VATS because this child was really poor, and we did a surgical thoracotomy and see the ultrasound after your thoracotomy. So this is the normal lung, and the fluid is almost gone. So this ultrasound actually helped me diagnose, and this is the pus. No way this can be pus be removed via chest tube, and that is why after 48 to 72 hours, if your patient is not improving, you have to choose either of the option, case-based, what is best for the baby at that point of time. And so surgical intervention. So we can do a surgical thoracotomy or VATS. VATS is video assisted. But yes, VATS is the preferred choice because it is less invasive, shorter length of stay, less complications. What is the aim of the surgery? Number 1, remove the entire infected material. Number 2, the lung expansion. So it's actually struggling, the child is getting ventilated, the child is worsening, the distress is worsening, you need the lung to expand back so you can go ahead with the decortication and organization. When you have, I saw organization of empyema, sometimes decortication is needed. The problem with the VATS is inexperienced hands. So again I said, you have to choose what is best available in your ICU and then treat this child, because it's not that we have to perform VATS in every patient. It's not like that. So again I will say, giving a fibrinolytic therapy or VATS is not the first option. It's when you are stuck. So we do not routinely recommend all this. So VATS, as you can see in this case, it is moving all the pus here and all the debris, and all the chest is getting irrigated. But the problem is, again, any surgical intervention has its own problems. Fibrinolytic therapy has a problem of bleeding. This has a problem of pneumothorax, pneumatococcus, BPF, bronchopleural fistula. So, and post-op remission, the patient will come and fight with you if the child again has a pus in his cavity. So this was basically the pneumonia with empyema. This thick pus was there in the small child, and she was given vancomycin. Again, I will emphasize 2 to 6 weeks. Sometimes we have to give and vancomycin for 14 days, and after that was discharged on oral antibiotics. We use linezolid, which is the oral option of vancomycin. Now, this was the basically stage where when we have organization, you might have to do some decortication in certain cases. Now, another, just to emphasize, कि हर patient में we don't have to do more and more and more. So this child, just because everything we have to decide at the bedside, case by case. So this was child admitted for 10 days with empyema, had a big chest tube in C2, but the chest tube stopped draining. And when the CT chest was done, you can see big bullas here. Big bullas, there is this is the pleural empyema, there are big bullas and all necrotizing pneumonia here. And once we did the ultrasound of this child, you can see here, there's not much of pleural fluid here, but yes, there is thickening here, there's some pleural fluid here. This child was actually referred to us for VATS. But when we saw this X-ray, just look at what our radiologist is talking here. Oh. So basically, there are big bullas, there are small bullas. And there are certain intrapleural bullas, there are certain bullas in the lung. So we all took a decision not to touch this baby. So because if we puncture through surgery in these bullas, the child might have a bronchopleural fistula or something bad would have happened to this child. So we actually did a conservative management of this patient, and you can see the thick pus and bullas here. And हमने क्या किया? We saw that the chest tube was actually deep way into the lung. So slowly, ultrasound guided, we withdrew the chest tube. So in the first sitting, we withdrew the chest tube to where a point this pus started draining. So with just a simple method, we withdrew the chest tube, and what happened? The air started coming out, the pus started coming out. So after 3-4 days again it stopped. Then we again withdrew the chest tube. And जैसे ये intrapleural bullous reduced in size, the intraparenchymal bullous also reduced in size. This child was actually discharged. And you can see the serial X-rays. This is the thick pus here. This has resolved. These are the small hematoceles here. And this is almost better, and this was just before discharge. And total 3 weeks in the hospital stay and discharge was on oral antibiotics. So necrotizing pneumonia. What is necrotizing pneumonia? Basically, you have necrosis in the consolidations. Always think gram negative also in such cases, because necrotizing pneumonia you have to cover and hit hard. You have to give both gram positive and gram negative cover, and these cavitations can eventually become pulmonary abscesses. And these are the small cavitations. Whenever you see an X-ray within cavitation with pneumonia, this is a necrotizing pneumonia. Give good antibiotics for 2 to 3 weeks, and at least only discharge when the child is afebrile up to 48 hours. There is no oxygen requirement. There is no evidence of uncontrolled sepsis, and the child is tolerating feeds, because this pneumonia can really be bad, and certain gram negative can't be covered on oral antibiotics. Try not to intervene. Try not to puncture these bullas. Try not to puncture these pneumatoceles. They can create a havoc. So last case, a 5-year-old child with fever, cough and cold for 2 days and worsening distress. And this child, we wanted to do VATS in this child, because this child was actually, this is his first CT, and you can see it's almost white on the right side. And this is our chest drain, which was there for 48 hours. It was draining, but the child still had very high grade fever, a lot of inflammatory markers going up, parents were getting panicked. So we did a rescan after 48-72 hours, but it actually showed a mild resolution. So you can see that you can start seeing that there is some, that it is reduced in size. It has reduced in size, the bullets have reduced in size, and we did a lung ultrasound, it showed some fluid. So we waited in this patient, and actually this patient resolved on its own. We didn't do any VATS. So the point is, decision is tricky at times, case-based. Look at the symptoms, hemodynamics, inflammatory markers, imaging and other social factors and acceptance of the patient, and decide what is best at your bedside. So this is about VATS and intrapleural fibrinolytic, and I said sometimes you have to decide on your own what is best for the baby, because uroconase definitely is less invasive, VATS is more invasive, but sometimes when you push to the wall, you have to do a surgical intervention. So serial X-ray, just wanted to show you, this is pleural thickening. So in this X-ray, look at this X-ray. You can't take it as pleural effusion. This is actually resolving pneumonia. So just wanted to show some 96%, about 78-90% of the cases, after the resolution of pneumonia, you get a pleural thickening. So this pleural thickening looks like this in the ultrasound, and don't treat this. You don't have to hospitalize this patient. This patient will be afebrile, inflammatory markers will be negative. Child would have received a good amount of antibiotics, and this pleural thickening is always there. Bronchopleural fistulas, yes, they sometimes havoc, and they need certain just. So my take-home messages is monitoring in pneumonia is very, very important. Any pneumonia which is not responding to IV antibiotics, look for complications. Watch your child. Why is it not improving? Is there any empyema, effusion, or necrotizing pneumonia? Lung ultrasound is a very, very crucial tool. And empyema not draining after the chest tube will need resolution by some other method, and via maybe thoracotomy or and streptokinase. And NIV modes, they've actually changed our life. We don't need to intubate all these children. They go do very well on NIV HFNC, and they have reduced our ventilation for to 40 to 50%. Thank you. And with this I want to announce this is our next series, and in the next coming up is the mechanical ventilation. It will be all simulation based workstations, and this will be happening on 21st of July in Ludhiana. Thank you very much.
So, ma'am,
transurate looks like just black fluid. So how do you differentiate exudate from empyema? Like, or it's same?
Diagnostic. See, sometimes you just have to do a diagnostic diagnostic.
So depending on lung ultrasound, can you
For
differentiate?
lung ultrasound alone will not tell you everything. You have to puncture this lung, take out some fluid, and do the test to find out what is happening.
The exudate also looks like some septations or something. And transurate doesn't have septation.
I have seen certain patients where there is no septation but pus came out.
Still it
Very
will
difficult to differentiate
Very
between
possible.
some straw blood fluid or pus. That's very
That would be depending on the abdomen. Right.
The best is to puncture and see what is happening inside.
Ma'am, is there any consensus regarding how much time you have to give IV and how much time you have to give oral antibiotics?
So I will just say one thing. Look at everything. How is the child? Is the child maintaining saturation in room air? Child should be afebrile for at least 2-3 days. The inflammatory markers should be negative. Your scans, your x-rays should show an improvement. And that is the time. चाहे वो 2 हफ्ते हो चाहे 3 हफ्ते. That is the time because IV will definitely work better in that situation than oral antibiotics. So look at the entire clinical picture. Afebrile, asymptomatic, good, no inflammatory markers positive, and last is your scans. Then you discharge the baby on oral antibiotics and keep following it up every 1 or 2 weeks to decide whether this child. So we do again. Our patient comes back after 1 week. We do a scan. We do sometimes do an inflammatory marker like CBC-CRP or something, and then decide the course of action. So maybe 3 weeks, 4 weeks of antibiotics more.
Can I add something?
Yes, please.
Sorry, I did not.
I welcome Anil sir.
I did not listen to your complete talk, but you must remember that empyema in pediatric patients is never primary. It is always secondary. In adults, primary empyema is known. So they may not have any parenchymal lesion, but they will have empyema. But in pediatric patients, it is always complications of pneumonia and particularly necrotizing pneumonia. As you said, we should follow the patient clinically and inflammatory markers and then decide about it. But usually it takes about 10 to 14 days of IV antibiotics. And then another, depending on how bad the lung was involved, another 3 to 4 weeks. On an average, it comes to around 6 to 8 weeks of total antibiotics. Regarding the your last 2 slides I attended, regarding the urokinase versus VATS and all, few years back I reviewed the topic for Hyderabad conference, and I understood one point that if the research which was done by surgeons was in favor of VATS and research which was done by pulmonologists was in favor of urocancerous. So there is no consensus at all. So it is always individualized approach, and you cannot recommend that go for this, go for this, go for this. But usually if on CT chest you find pleural thickening, you see a pleural thickening occurring and the patient is still running fever after 7 days or 10 days of antibiotics, you may try urokinase, but in such cases decortication of that is usually required, but there is no rule like that. And as you said, urokinase at a place, there is comparative studies are also there, but the cost factor is a big thing. Place is very expensive, but we have been using place at Gangaram and never had any problem. Never had any problem. And resolution and response is fantastic response. So I am not recommending place, but I am just saying that is how we are managing. But it is always individual approach. There is no guidance, no recommendation to this.
So I think we'll go
as the first talk has covered it, commonly it's allergic. It can be because of, quite commonly it's because of gastroesophageal reflux disease. I just want, for everyone sitting here, whenever a child who is coming to you, particularly the infant, young infant who is coming to the recurrent respiratory symptoms, recurrent cough, cold, recurrent nose blocks, always consider GERD as one of the commonest symptoms in this, and where you have to think about it, because many times what we do, we keep on treating the respiratory symptoms with nebulizations, with antihistaminics, but we always forget to add antacids in that treatment, and where the symptoms keep on coming, and even try to find out why the GERD is happening, because that's another problem which is leading to this recurrent respiratory symptoms. Then another common set of patients who are not very rare, who are we are seeing almost one patient in a month who is coming to us with recurrent pneumonias or recurrent distress. These are the cases who are having circulatory dysfunction, and they have recurrent infections, and because of advent of more and more this genetic tests are available very commonly, and at every place we are now diagnosing more these patients with more commonly these infections and these conditions, particularly cystic fibrosis. Then you have congenital defects where there is a problem with the feeding, and it's leading to recurrent aspiration, and these are the set which has H-type fistula. And then another common problem is swallowing dysfunction, where generally you don't find any problem which is anatomically leading to aspirations, but then there's a functional issue and the child is having a lot of aspiration, and because of swallowing dysfunction. And sometimes it can be an anatomical lesion in the airways, cyst compressing the airways, or some tracheomalacias. And lastly, foreign body is also very frequent, particularly in winters where we see a lot of this dry fruit being used in children also, so we tend to find a lot of organic foreign bodies in children. So many of the patients comes to us with stridor. This stridor can be present since birth, or this stridor can present at 1 or 2 months of age. Now whenever a stridor comes to us, we should remember this mnemonic, which is called as SPEXER. So how to always look for the severity of the airway obstruction according to parents. Fine? Because whenever the patient comes to you, patient might be sleeping, and that time he might not be having such a severe problem, but while the patient is awake or while feeding or while crying, what was the severity? So try to look at that. Ask about progression of the stridor. Third, whether there is any dysphagia, whether there is eating or feeding difficulties, whether there is a lot of aspiration happening or there is a failure to thrive. This point is very important. Many times, we being pediatricians, we keep listening to this stridor and we say that this stridor is because of laryngotracheomalacia and this will go away by itself, which generally happens in most of the cases. But when to say that this stridor needs to be addressed, when to say that this stridor needs to be investigated, this is the time when this patient is having eating or feeding issues, and this patient is not gaining weight as per his age. If the patient is not gaining weight, then this child needs to be investigated. And then we see cyanotic episodes, or the patient is having apneas, or now there is apparent life-threatening events, which is also called as BRU. This is now that it has progressed further. And or as for whether the child is symptomatic during sleep, or we call it as obstructive sleep apneas, where the obstruction is so severe that the child is having disturbed sleep. And R is radiology, like specific abnormalities which are even detected on radiographs. So you can remember this mnemonic. Whenever a child of stridor comes to you, try to ask these 6 specific symptoms, try to look for these symptoms, and you will be able to assess that whether this is a normal stridor or whether this is stridor which needs to be investigated. So another generalizations. Whenever it comes to you, look at whether this patient is more symptomatic in awake time or whether it is during sleep time. So obstruction, if it is worse during sleep time, then generally it's pharyngeal obstruction. Fine? And that means that it is mainly because of tonsils or adenoids are enlarged, or certain there are syndromic babies where the mid-face is small, the tongue is large, like and the patient is having Taylor-Robin syndrome, or with the patient is having cleft lip, cleft palate syndromes. These are the patients who will be more symptomatic during sleep, and the cause is mainly pharyngeal. If the obstruction is worse during awake, then the the exertion. Whenever the child is active, when the child is playing, when the child is crying, the child's spiral increases. Another thing you have to look is whether it is inspiratory or whether it is expiratory. Inspiratory obstruction is always extrathoracic. Fine. So these clues will give you, these points will give you some clue that what you have to look for. Inspiratory obstruction is extrathoracic, like generally it is leading, the cause is mainly lying in larynx. So it can be laryngomalacia, it can be bilateral vocal cord fallacy, or it can be subglottic stenosis. While expiratory obstruction is intrathoracic, it generally mimics asthma, and it's the involvement of the trachea or bronchi. Like particularly you come across a case of foreign body, and you will see many times now the stridor is inspiratory and expiratory both. Whenever you see expiratory stridor, that means that it's not only involvement of the supraglottic structures, it is now infraglottic, and the trachea and your bronchi are also involved. And it can be because of tracheomalacia, bronchomalacia, vestibular rings, or foreign bodies, or even some extrinsic compression. The pathology is lying in the mediastinum and it is compressing the trachea now. So I'll show you some cases. 6-month-old baby present with complaint of cough since 7 days, respiratory distress with audible wheeze since 2 days. Now this is the second episode in last 6 months. So any bronchiolitis which is occurring again and again, you have to think that it may not be viral, it is something else. So this baby is exclusively breastfed baby, and chest X-ray showing bilateral hyperinflation, and CBC, CRP is normal. And now again in the morning, the first session discussed that it can be bronchiolitis, but if it happens second, third episode, then you tend to get immunity to RSV, which is the main causative agent for bronchiolitis. Now even nowadays the vaccine is also getting available, and we have monoclonal antibodies as which should be acting as preventive agent. So get serum Ig levels and look at the eosinophil levels. And if they both are high, try to think that it can be possible cow milk protein intolerance. And this is happening not because directly feeding the child with formula feeds. This can be happening even if the mother is taking cow milk products. So this can even lead to cow milk protein intolerance in the baby. So we should advise mother to not to take milk and milk products, and child should not be on any milk-based products. Then only we can control this problem. And pointer to CMPA is the child is having eczema, or there is episode of blood in stools, recurrent wheeze, severe colic with regurgitation of feeds, and recurrent diarrhea. These are the pointers. These things are also present. Strongly suspect that this might be cow milk protein intolerance. Another case, 4-month-old baby present with persistent cough and nose block, baby on mixed feeds, weight is normal for age, history of excessive regurgitation of milk. On examination, nose blow present, bilateral chest is clear, throat is normal. So this is a GERD, fine. So whenever a child, 4 months baby, coming to you with recurrent cough, cold, again I told you that it can be GERD, you have to look into it, because many times you auscultate the chest is clear, but the child has a lot of noisy breathing, and this noisy breathing is mainly because of the nose block. And always try to clear the nose and use an antacid to prevent this GERD from creating a lot of pharyngitis, nasopharyngitis, which is actually leading to the recurrent respiratory symptoms here. So any child who is now 4 months of age and is on mixed feeding, so what we can do is we can shift the child to soya milk, and we can introduce semi-solids which should be wheat-free semi-solids even at 4 months of age. So this is, it's like any child who is breastfed, exclusively breastfed, he should be started on eating food after 6 months of age. But if the child is already on mixed feeding or exclusively on cow milk formula, then this child can be, we can do early weaning at 4 months of age. But we have to, we should avoid giving them gluten feeds. So particularly, we should avoid giving them wheat and oats. The child can be started on rice-based feeds, vegetables, and fruits like bananas and apples can also be used at this point of time. So this is case 3, 26 days old newborn referred to as persistent respiratory distress and failure to wean from CPAP since birth. Received multiple course of antibiotics and antifungals thinking of persistent pneumonia. X-ray revealed hyperinflation, thick secretion requiring repeated oral suctioning, persistent distress in a term newborn. Now what are the reasons behind it? So whenever a child who comes to you with persistent distress, we have to think that there can be some congenital upper airway anomaly. It can be because So in all these cases, whenever we have persistent distress, after initial investigation, if we are not finding out any clue, then we need to do bronchoscopy. In this case, when we did a bronchoscopy, we saw thick tenacious secretions, and they were very difficult to remove. Even the saline washes were given very difficult. And after bronchoscopy, patient improved for 24 to 48 hours. And we did bronchoscopy daily for 3-4 days to remove the whole secretion. Patient actually improved after we removed the secretion. And because secretion was so thick, so we suspected that probably this might be a case of cystic fibrosis because the patient is persistent distress. We took BAL also, which we used Pseudomonas, and patient improved. We gave antibiotics as for the Pseudomonas as per the sensitivity also, and the patient discharged. Genetics came out to be positive cystic fibrosis. And after that, we, along with antibiotic, we told the family to go for regular chest physio and good hydration. What I've seen is in all these young cases, even the child is less than 6 months of age, whosoever we diagnose as a case of cystic fibrosis, to liquefy their secretions along with good chest physiotherapy, we use a lot of ORS in these patients. And ORS has helped us to prevent the thickening of the secretions, and as the secretions become thin, so the child is able to cough them out very nicely, and the symptoms have reduced. I have almost 8 to 10 cases of cystic fibrosis in follow-up who were diagnosed at 2 to 3 months of age, and because of repeated use of ORS, they are doing very well. They have decreased the symptoms, and their hospital follow-ups are less now, and they are doing well. Similar type of cases can present with recurrent distress, recurrent diarrhea, failure to thrive, and you will have, you do a ABG, and you will have metabolic alkalosis, where CO2 is 45 and pH is 7.49 and bicarbonate is 35. And these patients sometimes they present with severe dehydration also. Respiratory symptoms will not be that severe, but they come to you with certain electrolyte imbalances where sodium is 123, potassium is 2.6, calcium is 5.6, and chloride is also 78. So this is a super water type of presentation. Generally, a child who comes to you and you find this type of electrolytes and metabolic alkalosis on ABG, you should always suspect that this is secondary to some primary pathology like cystic fibrosis. So we did a gene study in this patient also. It came out positive cystic fibrosis. Another one, a 45 days old male baby with recurrent right upper lobe collapse, recurrent distress, not gaining weight. So child was having recurrent aspiration pneumonias. So whenever, I told you, whenever you have persistent or recurrent distress, always think airway anomaly. So we did a diagnostic bronchoscopy, and in one case, we found that this child was having decapsule fistula. You can see an opening here. You can see another opening, small opening here. This opening is present almost around 2 centimeters above the carina. So now this is H-type decapsule fistula. In last 3 years, I think we have diagnosed around 7-8 cases of TEF which got operated, and now the children are doing well. So another common cause of recurrent aspiration is swallowing dysfunction, for example, vocal cord dysfunction or laryngeal cleft. We also saw a case of laryngeal cleft, which was a type 2 cleft, where you can see, if you see this video carefully, you will see that in between 2, 3, 4 breaths, one of the space here, it opens up. It opens up and shows you that it goes below the vocal cords, and this is the reason of recurrent aspirations. Where most of these patients who are type 1, type 2, you can manage on as a basis of swallowing dysfunction. These children, we generally keep them on tube feeds for 12 to 15 months. By the time that the children grow up, they start having good control of their pharyngeal muscles, and they start doing well, and the recurrent aspirations disappears. We have one such case from Bathinda where we kept this patient on tube feeds for 15 months. By 15 months, the child started, initially even the parents started saying that now the child is taking this semi-solid and solids well, but there was a problem with liquids. They started giving solids orally, and liquids were given through tube, and gradually they introduced liquids also, and the child started tolerating liquids also well, and there is no further admission after that. So another case we had 3-month-old failure to thrive, regurgitation of feeds. The child was well for 2 months, but at 3 months he suddenly had regurgitation of feeds, aspiration pneumonia. He had one episode of bleeding from the mouth followed by distress, and this child had this is a distal cleft. You can see the two bronchus here. These are the two bronchus, and this is esophagus here. If the line we have marked, you can see carefully. There is a you can see that even the NG tube is visible inside the trachea. You can see both openings of bronchus now, and below that opening at carina, this whole thing is connected with the esophagus. So this was probably a distal cleft, or it was a small thin papery membrane was there which got ruptured, and now this become a fistula. So we see a lot of cases of swallowing dysfunction also. As one swallow, it has 3 phases. It is oral phase, pharyngeal phase, and esophageal phase. And most of the time, the symptoms are more or less like a gastroesophageal reflux disease. The patient will have arcing while feeding, excessive crying, difficult to breastfeed, coughing or gagging while feeding. There is a lot of drooling, gurgly sound during or after meals, regurgitation, then failure to gain weight. You can do barium swallow, you can do endoscopy, you can do bronchoscopy. Most of the times the things are normal. If you do this technician scan, you will find some aspirations are there. To treat them with anti-reflux measures also, but then also this thing persisted. Many a times you on bronchoscopy you can have abnormal principal vocal cord movements here, where the vocal cords during expiration they are trying to opening up, and while inspiration they are trying to close. In these cases, most of these are reversible. They tend to improve with time, and you just have to put this patient on tube feeding for at least six months. And then once the patient is better, once the recurrent aspirations are not happening, then you start them with semi-solid food first, because semi-solid foods are easy to tolerate and easy to swallow rather than liquids. So then in older children, foreign body is the commonest cause. If there is sudden onset persistent cough or persistent wheeze or the localized wheeze, as told by Dr. Puneet, that in these cases then you have to think about foreign body. Sometimes laryngeal foreign bodies, they present as sudden onset stridor, where you have to do direct laryngoscopy or bronchoscopy where you find foreign body. One such case presented to us where the child started suddenly having stridor. And when we did a direct laryngoscopy, we found a small toy which is included in this cracks packet. And because these are easily available, child was eating that packet and he ate that toy also, and which got stuck in between his vocal cords. This 7-day-old baby, stridor since birth, failure to thrive, persistent oxygen requirement. Now this child was not getting managed, was not able to discharge. So see, you can see the vocal cord movements here. Hardly the vocal cords are moving. So this is a case of vocal cord palsy. Again, very common. We get referrals from neurology centers where they say that the child is not able to extubate it, or the child is not getting weaned off. Child is bit better in the prone position, but persistent oxygen requirement is there. These are the cases where generally this is bilateral vocal cord paralysis, I will more say, because again, whenever a case of bilateral vocal cord palsy comes to you, you have to do 2-3 things. One, MRI brain. Second is echo. Because certain congenital heart diseases can lead to palsy of recurrent laryngeal nerve, or there can be some intracranial abnormalities which can lead to bilateral vocal cord palsy. If both the things are normal, then it is transient one, generally improves by around 1 year of age. Most of the kids, they tend to do better by 6 months. So if the child is not maintaining well without oxygen and persistently symptomatic, then treatment is doing tracheostomy in these patients, and you have to keep on reviewing them after 3 months. If you keep on looking at the vocal cord movements, and right few days back we have decannulated another patient at 9 months of age. Child was symptomatic, referred to us from CMC, got tracheostomized at 15 days of life, and we followed. We did one bronchoscopy at 3 months. It was no much improvement. At 6 months, around 50% movement was there. By 9 months, the child movements were not normal, but we then partially blocked the tube and saw we decreased the size and partially blocked the tube and saw the child was maintaining well. So we removed it. The child is still having stridor, but is playful, active, and growing well. So another case, 2-month-old infant presented with increasing stridor along with respiratory distress. Child had history of severe pneumonia with respiratory failure which he was on ventilator for 5 days and extubated. Gradually developed stridor which is increasing. Now you can see this picture. This was his condition of subglottis, which is almost blocked. Very small opening was seen during inspiration. So for these cases, wherever the stridor is present after extubation, most of these patients, they have transient stridor. Nowadays what we are doing is, if the patient has stridor, we go in and see. Many times we find a small web which is papery thin and we remove it through bronchoscope. And these children tend to do very well. But the children who comes to us late, at 1 month, almost whenever we do bronchoscopy, we generally find this kind of picture where now it's a thick fibrous strand which are not papery thin and cannot remove the scope itself. So here what we have to do is, because of the thick fibrous band now, it is not possible to open it without having an alternate airway requirement. So first these patients need to be tracheostomized because we need to have another airway opening. And then after that we do balloon dilatation. You can see the Syrian balloon dilatation we are doing. We first create a path, we check that this path is leading to the main trachea only. And then first with the boogie and then with the balloon, we do it with 5 mm balloon, with 10 mm balloon and then 12 mm balloon. And in the end you can see that the opening is quite big now. Then we do this ballooning after 6 weeks. And we tell to the family that this patient requires tracheostomy for at least 6 months, because we have seen in 8 to 10 cases of what we have done till now is that these patients require re-ballooning 3 to 4 times. After that, this opening remains stable and we are able to decannulate these patients. Another case, 9-month-old infant presented with normal breathing sounds along with persistent distress since 1 month. Patient was alright while sleep, while distress used to worsen while feeding and drying. So possibility of laryngotracheoplasia was kept, and but once we went inside, we found that subprolapsing epiglottis, which was leading to this, and generally this prolapsing epiglottis, it's not primary thing, it is secondary to some other obstruction, and this obstruction commonly seen either there is obstruction in the nasopharyngeal area or you can see some intrathoracic cause of obstruction. Once we went inside, we found that the left bronchus opening was very narrow in this child, and even it was very evident on X-ray also that the left lung size was less. So probably that was leading to increased inspiratory efforts, which was leading to this prolapse of epiglottis inside the bronchus. Here, you have to wait and watch if the child is not very symptomatic and maintaining well, but if the child requires return hospitalization, then this epiglottopexy can also be done for this very flexible this epiglottis, very elastic epiglottis. So another case, 8-year-old child presented with hoarseness of voice and recurrent sighing breaths. You can see this video here. See how he is breathing. No histiodysphagia, drooling of saliva, and the child, after every 3-4 months breath, he breathes like this, like he is having some obstruction. So we did direct laryngoscopy, which was normal, but then we did a bronchoscopy. So you can see here, you can make out here, a small bluish swelling just below the vocal cords, and it is almost covering the whole from 6 o'clock to 12 o'clock position, the whole of the left side, this one. So this is, when it's a bluish swelling, generally there is a this upper airway tract hemangioma. So what we did, because the patient was quite poor, he was not ready to go for any further treatment, so I gave him propranolol trial. Gave him propranolol for 3 months and his symptoms improved, and he became asymptomatic, but he never allowed me to do another scopy, but the child was clinically better, so I probably thought the child improved and the hemangioma resolved. So any questions?
Just a few comments on one you mentioned, decreasing mother's milk. Mother's milk, consumption of dairy products for the mother. In GER,
has been shown in now various studies that even the milk which is consumed by mother can affect the quality of the breast milk, and the children who are fed on breast milk of the mother who is taking cow milk, and if they are getting GERD, if they are getting eczema, if they are getting blood in stools or recurrent wheeze, then this is also one intervention which you can do, is that tell the mother not to take milk products, and you will see the IgE levels. If they are high, they will come down, and symptomatically patients tend to do better.
GERD independent of CMP.
It's basically a type of a CMP. So CMP doesn't mean that only direct feeding of the baby with cow milk. It can develop because of even the mother is taking.
So choice of attaching GERD below 6 months.
It's a remedy. First line is remedy. If it is not effective, then you can go for this proton pump inhibitors. It depends. What I feel is that the dose and convenience to give is very important. Escoprozole you have to dissolve in 10 ml, and very difficult to give 10 ml to a small child. So lansoprazole dispersible tablets are available. You can hardly dissolve in a spoon of water or half spoon of water, and it's easier to give. Otherwise, most of the time symptoms, the effect as I feel it's same, not much difference.
How long?
You have to use short courses initially, and you try to remove the cause of GERD. And if the GERD is persisting, then you can use it, because the GERD tends to resolve as the child grows. The child will have a very severe GERD in 1 month of age, but by the same child on same age, he will become very less symptomatic at 5 months of age. So tell the family if it's happening again and again, they can take short courses, maybe 5 days, once in a month or twice in a month, depending on the severity of the symptoms. But many times the parents tend to have this notion: any crying, any reflux has to be treated. It's not like that. If the child is in distress, you are in distress, he's not sleeping, he's not gaining weight, not letting you to sleep, assess the severity of the GERD, then only treat it. Not every reflux should be treated.
I have seen the case of laryngeal flare. So the child was being treated for respiration pneumonia repeatedly outside. So the catch was, as the child was admitted in our hospital, I have seen the case. The catch was that when they started the feed again, the child had a history of, the child started coughing. That was again, there's some swelling problem in that child.
Yes. So I told you, in swallowing dysfunction, you have to assess that whether the problem is during feeding or whether the problem is happening after 10-15 minutes of feeding. After 10-15 minutes, it's probably GERD. During feeding, then it's basically.
When we kept the child elevated, it's stable.
Yes.
When we restarted the feed again, the child again started having the cough.
Yes.
That was the view in that case.
Yes. So I think with that we close our session. I welcome Dr. Karmir Goel, our PMC member, who has spared and given us time, and he has also given us 3 credit hours for this CME. I just welcome him here, and I wish that everybody should give him a good round. He is Director of Pediatric Intensive Care in Gangaram Hospital, New Delhi. And I am really honored that I have done my fellowship under his training. And whatever we are doing today is all because of his training.
Very nice of you to come here to Jhanan, this scorching heat, and your valuable experience and everything to the delegates. And I really congratulate you for organizing such CME in this heat, and very good attendance.
Thank you.
That means everybody who is coming here at this hour and this time of the year is really interested in the learning and adding to one's already rich experience and knowledge. I think this is for everyone.
Even Srinagar.
And that's lovely. Coming from Srinagar, another 2 credit marks.
We have delegates from Katwa also.
Of course, we have very good faculty. Dr. Puni, I'm seeing here, Dr. Vikas is there, but with your starring, I think it adds to the value of the conference. Once again, congratulations.
There is small that how to work in a team and how to diagnose and how to manage cases as a team.
Sir is going to speak about the normal and bread and butter of pediatric ICU, pediatric ARDS. When the pneumonia progresses to a condition called ARDS, and what is our new modalities, what is new in ARDS, and everything.
Okay, thank you very much, Dr. Vikas, Dr. Mahak, and all others for inviting me. I had always been thinking, actually I am from Punjab, my parents were from Punjab, Amritsar, and I was very much keen in developing and evolving intensive care in Punjab. And many years back, Dr. Puneet had attended critical care course at, we used to conduct 7-day course at Nagaram. We did that for 25 years, and she attended, I think, once or twice? Once. So then few other fellows who came to Amritsar, they got into the rut of general pediatrics, and they forgot about the intensive care. But I am very, very happy to see that Vikas and Mahak, and along with Dr. Puneet, now I can see evolution of intensive care in this part of the country. And in the last talk, Dr. Vikas has summarized the whole of pediatric pulmonology in 10 to 12 cases, which are very commonly seen, and sometimes it is very difficult to diagnose and to manage. But yes, you have to have a very wider spectrum of thoughts and differential diagnosis in these patients. Now, the talk given to me is ARDS. So I called her Dr. Mahak and I asked her, क्या बोलना है मेरे को? Because ARDS is a textbook in itself, I mean, I'm still learning ARDS. So she said, you just stress on the clinical, the ICU side, bedside, what we do actually in the management of ARDS. So that is why I have titled it as ARDS, Diagnosis and Management. And this condition is known for many, many years. Ashpath was the first one to describe this and named it as white out lung, non-cardiogenic pulmonary edema, then shock lung. There are many names. Adult respiratory distress syndrome, like in neonates we have RDS, in older kids and adults we used to have, it was named as adult respiratory distress syndrome, but now it is acute respiratory distress syndrome. So this is my hospital. Another building, 10th floor building is coming up, just adjoining. This is the old picture, and this is my ICU, 12-bed ICU with the state-of-the-art equipments, everything, and I'm lucky to be there for the last 35 years. So I'll start with the case. It's always easy to follow a case and then, learn the management. So this was a 4-year-old child admitted few years back in the evening with history of ingestion of kerosene about 5 hours back, followed by cough and fast breathing for 3 hours. Child was conscious. There was tachypnea, tachycardia, blood pressure was 95/68, saturation 95% in non-breathing mass. There were no seizures, no vomiting, and was shifted to ICU. And NIV, that is BiPAP, was planned. We planned to start on BiPAP. So this was the first X-ray. It is almost normal, except for few infiltrates you can see on the left side at the basis. So this child was started on NIV, face mask with FiO2 of 0.5, inspiratory positive pressure of child was settling down, tachypnea, tachycardia was settling down. 6 hours after admission, the child was getting restless, he vomited and he had a generalized tonic-clonic seizure. Hemodynamically getting unstable and increased work of breathing and desaturation. The patient was taken on invasive ventilation, orotracheal intubation was done and put on pressure regulated volume control ventilation. That is what we have in our machine. So the pH was bad, 7.23 was the pH, PCO2 47 by PO2 94, lactate of 3.18 and BICAR of 21. And the PF ratio was 160 and oxygen index was 15. So I will describe what is PF and what is OI ratio. So all this indicates that the patient has worsened, patient has gone into acute respiratory distress, acute respiratory failure, and there is a problem with the hemodynamics because lactates are 3.18. So there is cardiopulmonary instability. And the PF ratio has gone down to 160, which is very poor, and oxygen index usually less than 4 or less than 4 is gone to 15. So this is the X-ray, which is again telling us that the things have worsened. There is a bilateral fluffy shadows on all the zones of the X-ray. So patient was put on invasive ventilation. Now we started the management of ARDS, peak titration, inotropic support was started. Peak pressures were coming to around 35, which is way high. Mean airway pressure was 25, which is again very high, and pH was worsening. pH of 6.9, PCO2 93, PO2 57, and BICAR is still 21, not bad. Lactate is 1.12, that is probably because we started inotropes. His PF ratio has worsened from 160 to 57, and OI has worsened from 15 to 43. So what to do next? So our peak titration, our conventional ventilation is not helping the child. So we have to think of something else. So this child came with a mild ARDS and progressed to severe ARDS. So this is the X-ray at this stage, totally white out lungs. So refractory hypoxemia. So this child is in refractory hypoxemia right now. So it is the increase in PO2 by less than 5 millimeters. If you increase the FiO2 by 10%, then PO2 is less than 60 or PF ratio less than 100 or on FiO2 of 80 to 100%, requiring more than 5 centimeter of peak pressure, and the plateau pressure, that is again peak and plateau pressure, more than 30. Oxygen index is one parameter that we should measure in all these patients and keep a trend of that, and this is the formula to measure. It is basically the ratio of mean airway pressure divided by PF ratio, that is PO to FiO2. So that will come to FiO2 into MAP divided by PO2 into 100. So this is how it was started in 1994. American, European people, they made a consensus conference, and it was in 94. These diagnostic criteria were laid down, and this condition was divided into acute lung injury and ARDS based on the level of the peak, chest X-ray findings, and the PF ratio. So the ARDS was originally explained when the PF ratio was less than 200, and ALI, that is acute lung injury, when the PF ratio was less than 300. Then from 94 to 2012, we followed this classification, this definition, and there were no pediatric. This is just a common thing. Everybody will use and classify and publish lots of papers on these diagnostic criteria. And then in 2012, Berlin definition for ARDS and expanded rational justification and supplementary material were published in the intensive care medicine. So over here, they deleted the term ALI, that is acute lung injury, and categorized the ARDS into mild, moderate, and severe. Over here, they included the time that the insult for the lung was within a week, and then the origin of edema was not related to the cardiac cause. So there was a need to do echocardiography. And second, the oxygenation levels were again depending important because it required another maneuver to do. So basically it was the time, it was the cause of edema, oxygen level and the chest findings. So the ALI was eliminated. Then the minimum 5 centimeter peak was required to define this ARDS or different categories of ARDS, and determination of cardiac failure were more subjective because we were by this time, by 2012, the pulmonary artery catheters were out of the ICUs in adults. We never used pediatric pulmonary catheters, so it was more of a subjective or echocardiographic based. The shortcomings were that we required invasive measurement, because the arterial line has to be there to know the PaO2, right? So that was a major limitation, especially in the resource limited setting where the arterial lines are not done everywhere. So the risk factors were not involved, the etiologies were not considered, pathophysiology, as we are now talking about the phenotypes and endotypes of ARDS, there was no mention of all these things, and the outcome of adult ARDS, like ARDS in adult patients and the children are totally different. In children the outcome is much better than the adult, but these aspects were not considered. So the Berlin designation was basically for the adults and not for the pediatrics. Then 3 years later, in 2015, we had pediatric acute lung injury consensus definition, and here, because many units started using invasive ventilation, so the invasive ventilation was also included, and non-invasive ventilation as well as invasive ventilation were used for the classification or for the consideration of the oxygenation part. So full face mask with the bi-level ventilation, I will explain what is that, and the PF ratio or SF ratio. We all have pulse ox in our ICUs. So SF is saturation divided by FiO2. So that is what the SF ratio is, and the cutoffs were given. And second is patient with cyanotic heart disease. These are the special populations which were totally ignored in the Berlin definition were included. We have lots of prematures which we are saving, and they are suffering with some form of chronic lung disease. They were also considered, and of course they laid down the criteria for the left ventricular dysfunction. Now, after 7 years, after 8 years, in February 23, we had PICS 2 guidelines. Now, this is the latest that we are following. Over here, in the previous 2015, the category was mild, moderate, and severe. But over here, now mild and moderate are clubbed into one, and the severe is different. So we have only 2 categories. One is mild, moderate, or severe. So that is the one major change. Again, they have included in non-invasive ventilation, they have defined cutoffs for non-invasive as well as for the invasive ventilation. Another cyanotic heart disease, chronic lung disease, again they are included, and the oxygenation is advised that should be measured in a steady state. Initial phases, initial 1 to 2 hour, patient is in a very dynamic state. So you should measure the oxygenation level at after some time, and they define that level as 4 hours. 4 hours. So when you want to classify a patient into mild, moderate or severe, then you should spend time, stabilize the patient, and at around 4 hours you categorize or stratify your patient in what category the patient falls into. So why did they choose? Because hypoxemia at 6 hours of pediatric ARDS, onset was better, discriminating the mortality. So that is why they included 4 hours, because their logic was that if we give 6 hours, then it may affect the initiation of the treatment. So they chose the 4 hours of time period to classify and stratify the patient. Why they clubbed the mild and moderate? Because there was not much difference. If you can see in the graph, less than 4 to 8, the mortality is almost same in the first 2 bars as compared to the previous last one, which is more than 16, that is the severe ARDS. So there is not much difference in the mortality if you club the mild and moderate ARDS. So it will simplify the classification. more accurate classification will be there, and the patient's more frequent use of this will be there. So when they analyze, this is a paper published in 2019. So again, you can see the mortality in the mild ARDS, moderate ARDS was around 12% and the 10%. So not much difference. So that was the reason they clubbed mild and moderate together. So another very important for the resource limited condition, they came up with the term called possible ARDS and at-risk ARDS, which were totally ignored previously. So possible ARDS is again defined as depending on the patient who is on nasal oxygen flow, simple high frequency, high flow nasal canvas we are using. So they have defined the cutoffs for that also. So when a patient has a FI to PO to FI to ratio or SF ratio is less than 250, then he is a possible ARDS. X-rays are not available everywhere. So they say that if the patient fulfills the criteria of timing, origin of edema, and chest findings, X-ray, the oxygen markers, but X-ray is not available, you can classify that patient as possible ARDS and treat him like an ARDS patient. Now another term is at-risk patients. Any patient who is on oxygen and requiring oxygen to maintain saturation above 88%, then these patients are at-risk ARDS. So our patient, if you remember, started with a mild ARDS, was managed with the NIV, and then it progressed to severe ARDS. So remember, ARDS is a very, very dynamic situation. So if you look at this, again, the same oxygenation criteria and the diagnosis depending on the OI, that is oxygen index, and the OSI, that is oxygen saturation index, and you can have IMV, invasive mechanical ventilation ARDS, non-invasive ventilation ARDS, at-risk PRDS. So all these can be classified, but the message is that if your patient has possible ARDS, treat him like ARDS. That is the basic thing. I will not bore you at all with the physiology, but this is the basic thing that you have to understand. We used to say that ARDS is a disease of stiff lungs. It is no more a concept. ARDS is a disease of small lungs. We are ventilating the lung which is not affected, which is not infiltrated, which is where the alveoli are either partially recruited or recruited. So it is no more a disease of stiff lungs. It is a disease of small lungs. So that is why a concept of baby lung concept is there. So whatever settings you are doing on the ventilator, whether invasive or non-invasive, should be kept with the concept that how much is the ventilating lung. If you are using normal ventilatory settings, pressure settings, tidal volume settings, in a patient who has just 1/3 lung left for the ventilation, you are going to harm the patient. So that is the basic concept, that the tidal volume should be set according to the size of the baby lung. Now the question is, how do I find out the size of the baby lung? The baby lung size, the only way to find out is CT scan. But it is not possible. It is practically not possible because all these kids are very, very sick. So I'll tell you how to do this. So what we know about ARDS is that patients of ARDS mostly die because of the iatrogenic ventilator-induced lung injury. They have prolonged ICU stay, they have prolonged morbidity, they have prolonged hospitalization, and many of them die because of the ventilator-induced lung injury. Because of the barotrauma, when we are using excessive pressure, because of the excessive volume when we are using, so we are overexpanding the normal lung, which is the baby lung, or atelectotrauma. We are repeatedly opening and closing the partially recruited lung, partially functional alveoli. So that is what is called as atelectotrauma. And when we are opening and closing the alveoli, the cytokines are released, and that is the cause of biotrauma. So this is how 4 mechanisms are involved in inducing the ventilator lung injury. This is again the same concept. In normal, we have good gas to tissue ratio, but in the ARDS patient, because the alveoli are filled with fluid there are lots of changes occur in the epithelium, endothelium, so the gas proportion in the ARDS is reduced. Again, there are three or four types of alveoli which will be there in the ARDS patient. One is inflated alveoli, which are normal alveoli. Remember, ARDS is a heterogeneous disease. It's a heterogeneous disease. So, majority of the brunt of the disease is in the posterior dorsal part of the lungs. So, posterior dorsal part of the lung. So, some of the alveoli are inflated, some are partially collapsed, some are totally collapsed, and some are consolidated. Now, consolidated means they are filled with the proteinaceous material. So, whatever pressure you are using is going to affect each one of them. If you are adding pressure, the alveoli which are totally collapsed will not get opened up. The alveoli which are normal will get overinflated. Some of the alveoli which are partially collapsed will get recruited, and consolidated lung which will also not get recruited because of this. Now we come to the management part. Once we have diagnosed, we have categorized our patients, stratified our patient, and all these things need to be done. We are not focusing only on ventilation. Everybody thinks that ARDS is ventilation. No, it's not. The non-ventilatory management is also very important, because if you are not giving care to the non-ventilatory, non-pulmonary management, then the patient outcome will be very much different. So I will just touch upon few of these things. So the goal of mechanical ventilation in the ARDS is not to maintain normal gases. That is the bottom line. I am not ventilating normal lung, I am ventilating diseased lung. So we are not targeting normal blood gases, but rather we are trying to optimize the oxygen delivery and protect the lung from the lung injury, from the ventilator lung injury. So this is the patient. So our patient arrived in mild ARDS. We started this child on NIV. So can anybody tell me why did we start NIV and not high flow nasal cannula? Remember, high flow nasal cannula is the modality which will work best when you are dealing with airway diseases, when you are dealing with medium size or small size airway diseases like bronchiolitis. Bronchiolitis is a disease of small airways. But over here our patient had kerosene ingestion. So we were expecting parenchymal disease. So if you go through the literature of high flow nasal cannula, you will find that 90% outcome is good in 90% of patients in bronchiolitis, around 50-60% in asthma patients, but in pneumonia patients, HFNC works in 30-40% of patients, because pneumonia is a disease of parenchyma. So whenever we have a disease of parenchyma, we need some pressure to inflate the alveoli. We need some pressure to open the alveoli. They say that during high flow nasal cannula, there is some positive pressure at the alveolar level, but we really don't know how much is there. So high flow nasal cannula is usually, we say, when we are delivering more than 2 liters per kg, or 1.5 to 2 liters per kg gas flow to the patient. So these are the different components. You need a gas blender, you need a humidifier, you need a heater, and cannula, and heated circuits are required. So these are the different mechanisms. It reduces the work of breathing, it reduces the inspiratory resistance, it washes out the nasopharyngeal and dead space, leading to better alveolar ventilation and improvement in lung compliance and mucociliary function. I think out of all these mechanisms, the most important thing that I can understand is the mucociliary function. That is the best, because we are giving humidified, heated oxygen, gas to the child. So when the gases are heated, so there is a lamellar flow. When we are just giving nasal prong and connecting to this, cylinder or something, those are cold gas. So cold gas is not good for the mucociliary function. So this is how all these 5 mechanisms on the top row you can see, and how they reduce the dead space, the work of breathing, the resistance of the nasal passages, then improve the compliance. By improving compliance, there is a decrease in the respiratory rate, the work of breathing reduces, there is less stress and strain on the lungs, and then there is patient is more comfortable, the diaphragm lung injury is not there, ventilator induced lung injury is not there, oxygenation is better. So this is the patient now on NIV, right? So in NIV we are setting the pressures. In high flow nasal cannula we are setting the flows. So that is the basic. So that is a flow based device. NIV is a pressure based device, right? So this is a patient who is on full mask NIV. So it also reduces the work of breathing, avoid respiratory muscle fatigue, increases tidal volume, and the CPAP is there to counter the intrinsic weave, or it helps in the recruitment of the alveoli, so preventing the atelectasis in these patients. So there are basically two modes, the BiPAP and the CPAP. BiPAP we use when we want to support inspiration as well as expiration. So we set two pressures, one is the expiratory positive airway pressure, that is EPAP, and the inspiratory positive pressure, that is IPAP. While in CPAP there is only one pressure that you set, and that remains throughout the whole respiratory cycle. There are different modes of BiPAP, spontaneous, timed, and spontaneous supported. The different interfaces are available. So what I want to say, when you are using NIV in a sick child like ARDS patient, avoid using standalone BiPAP machines. Use your conventional ventilator. All ventilator companies are providing you with the mask and the double tubing. So when we are using non-vented mask, so in single tubing mask you will have a vent for the CO2 removal. But when you are using double tubing from the conventional ventilator, that Dragar, Mackay, whatever you are using, so they have double tubing, so then we use the non-vented mask. So in acute respiratory conditions, we use non-vented mask with the double tubing. So that is one very important aspect that you should remember. So double tubing we use with the non-vented mask. So BiPAP setting usually you start when the patient is in a semi-inclined position. Reassure the child. Don't start with a normal setting of 12 IPAP and 6. No, don't start with that. The flows are very high. A child who is already in an increased work of breathing will get scared with such a pressure. So start with the lower IPAP and lower EPAP. Stand at the bedside. Titrate your pressures every 15-20 minutes by 1 2 centimeter and reach your target. Don't start with your target on the first occasion. That's very important message I want to give. So we can usually try to start with the 5 to 8 IPAP, 3 to 5 EPAP, and FiO2 4.2. You can start with 100% initially, but you should try to come back to 0.6. So maximum IPAP, the studies have shown you should not cross 15, and maximum EPAP 8 to 10 centimeters. If your patient requirement is more than that, then you need to go on to the invasive ventilation. One more important message I want to give for the high flow nasal cannula and for the non-invasive ventilation. The clinical monitoring is the best. Don't depend on blood gases. Clinical monitoring and saturation monitoring. If a patient is getting comfortable, his work of breathing is better, his heart rates are coming down, his respiratory rates are coming down, there is no hurry to do blood gases. You do it after 2 hours or so. While in patient who is on invasive ventilation, intubated patients, whenever we make any change after 20 minutes, we try to do blood gases. So this is what we have already told you. So trigger and cycling also, when we use the conventional machines like big ventilator machines, we can set the rise time, trigger, all these things we can set. We can set the FiO2 also. So this is what this is a very important graph from one of the studies published in intensive care, pediatric intensive care. So if you see the dotted line, the black line, which is a patient who are on NIV, all the patients on NIV, and this is at 0 hours the NIV was started, 2 hours, 8 hours and 12 hours. So there is and on the y-axis you can see the saturation SF ratio, the median SF ratio percentage change. So there is a consistent rise in the SF ratio. So it is very important to follow SF ratio. Whatever saturation you are looking at the monitor, must be taken in context with the supply of oxygen to the patient. If a patient is maintaining 95 saturation at 100%, his SF ratio is 95. But 95 saturation, if you say, tell me my resident says, child is 95 saturation, I always ask, what is the FiO2? So it's very important to take this ratio into account when you are assessing the patient, right? So if you see the black dotted line, there is a consistent rise in the SF ratio, while in the green line, which are the failure patients who are on NIV, you can see there is a rise, but it has never crossed the 170 mark. So our definition of NIV is when the SF ratio is less than 200, right? So this is failure, and those consistent change in SF ratio along with clinical improvement, heart rate, respiratory rate, work of breathing, sensorium, child is comfortably sleeping, irritability has gone. So in patients who have possible ARDS according to PALIC 2 or at risk, we should always give a trial of high flow nasal cannula or non-invasive ventilation, but it is time limited trial. You cannot keep on going for 6-8 hours. If your patient is not showing improvement, what I have already enumerated, in next 2 to 3 hours, be ready and intubate this patient. So it is very clearly written, time limited trial of non-invasive ventilation. So you cannot leave this child on non-invasive ventilation at all. So this is a typical ARDS X-ray which you have already seen, and the CT scan. Now there is before we go into the nitty-gritties of ventilation, there is one concept of driving pressure. Now what is driving pressure? Now driving pressure is very simple to calculate at the bedside. What is the plateau pressure minus peak that you have set. So that is what is the driving pressure. What is plateau pressure? There is three pressures. One is mean airway pressure, then is the peak inspiratory pressure, and is the plateau pressure, right? So peak inspiratory pressure is the highest pressure that you achieve at the end of inspiration, right? When the flows are on. Plateau pressure is highest pressure that is achieved when the flows are stopped, correct? So peak pressures are always higher than the plateau pressure, and this is when these two are different in patients who are on volume controlled ventilation. But when your patient is on pressure controlled ventilation, in majority of the situations these are the same, correct? So driving pressure is basically to tell you the relationship between the tidal volume and the respiratory compliance. So you see there is a ratio of tidal volume and the respiratory compliance. So this is, you can calculate by subtracting peak positive and expiratory pressure from the plateau pressure, correct? So this is basically again based on the concept of baby lung. So that is the respiratory compliance is the whatever lung is left for the ventilation, we are whatever machine is showing the compliance, dynamic compliance, static compliance is the compliance of the baby lung. It is not showing the compliance of the whole lung or the chest wall. So this is the concept that you must understand. The driving pressure is plateau pressure minus P, but if you are unable to measure the plateau pressure, you can take PIP, that is peak inspiratory pressure minus positive and expiratory pressure. So this is a paper which changed the concept of ventilation in our patients of ARDS. This is a retrospective paper, huge study, very well done, complex statistical work done. I will not go into the details, but they showed that if the driving pressure is rising consistently, as you can see in the first graph, the mortality was increasing. The mortality was increasing. So if the driving pressure was increasing, so if the driving pressure was normalized, you did not allow the driving pressure to increase beyond 15, then the mortality was low. But if the driving pressure was rising, then the mortality was high. So whenever now in our unit, after this paper, the driving pressure is mentioned in the notes of the fellows, that this is the driving pressure in the last 6 hours. Because our nurses are noting down the plateau pressure, peak everything. So fellows know now. Even the nurses now know about what is driving pressure. So this is our paper published in 2021 in respiratory care. Over here we had, this is again a retrospective, 300 patients. This one? Okay, thank you. So this is 101 patients we analyzed, and over here we also found, we classified them into tidal volume. According to tidal volume, 6 ml or 6 to 8 ml, driving pressure 15, less than 15 or more than 15, and then according to PALI 2015, because by this time the PALI 2 guidelines were not available. So we had 65 patients of ARDS, and you can see the morbidity pattern of our patients with the low driving pressure and high driving pressure, the duration of ventilation, the ventilator free days, the length of ICU stay, length of hospital stay, all were significantly different, lower in patients with the low driving pressure category. And we found that the driving pressure of 19 or more than 19 was associated with increased mortality. But the standard these days, that most accepted number is 15 to 16 centimeters of driving pressure. And analysis of ARDS patients, again the same durations that I have told you, morbidities, and we found that the oxygen index more than 8, presence of multi-organ dysfunction, and the fluid balance were the determinants of the mortality and not the driving pressure. The driving pressure was, in univariate analysis was significant, but not in multivariate analysis. And there are many papers in pediatrics where again they show that the driving pressure is not the determinant of mortality in pediatric ARDS. So which modes we should use in ARDS? So you can use any mode, whatever you are comfortable with, but you should know in detail, in depth, that what mode I am going to use. So you can use volume control, you can use pressure control, or as in my unit we use PRVC. Lung protective ventilation, the concept is that we should not give high tidal volumes, again based on the concept of baby lung. So we are ventilating, we are providing tidal volume for the baby lung. We are not providing tidal volume for the collapsed or the densely involved lung. So tidal volume of usually we say 6 ml per kg of the predicted body weight, and the plateau pressure target is 30 or less than 30. Now this number has come down to 28. And a PEEP is required to prevent end expiratory alveolar collapse, which I have already explained to you, alveoatelectasis, alveotrauma, atelectrotrauma, because if you inflate the lung, deflate the lung, inflate the lung, so PEEP is going to prevent this end expiratory collapse. So that is what it is. The PEEP requirement is there, and we should keep watch on the plateau pressure to minimize the alveolar overdestination. So many times low protective lung ventilation fails to achieve satisfactory blood gases, but it is fine. We are not targeting. Our PO2 should be above 50. In the very bad cases, PO2 50 or above 50 is fine. Permissive hypercapnia, that is, you allow CO2 to rise and keep a watch on the PCO2. So these are some landmark trials where we came to know that the low tidal volume is beneficial for the survival, and there was significant difference in mortality of almost 10%. Then there were other trials, the Elver trial, Love trial, where they showed that the high PEEP is required in patients because of the concept of the end expiratory alveolar collapse, but it did not affect the mortality. Now in PALI 2, they say 6 to 8 ml, and we should avoid supraphysiological tidal volume above 8 ml, and less than 6 ml we should use very carefully, keeping a watch on the plateau pressure and the driving pressure. And if you want to ventilate a child with 4 ml or less than 4 ml, then you have to be extremely careful, because you may induce, because you're not giving enough gas for the alveoli, so even your baby lung will collapse. So that is what it is. But the recommendation is 6 to 8 ml. So whenever you're starting a patient, you start with 6 ml per kg and play with the tidal volume by 0.5 or 6 to 6.57 or 5.5 or 5, like that, depending on the plateau pressure and your other clinical hemodynamic parameters. Positive and expiratory pressure. How to set the PEEP? It's very easy for every speaker to say optimize the PEEP. Now, how to achieve this optimization? That is very important. So there are ways to do it. You can follow any way, or you can use 2-3 ways. But it is always, you have to take You have to look at the end tidal CO2 or your CO2. So this is how the optimization going to help you. Optimization of tissue oxygenation, compliance, intrapulmonary shunting will reduce, mixed venous saturation will improve, adequate oxygenation, PF ratios at 0.5, FiO2 should be above 60, PO2 above 60, and low physiological dead space. So what we are doing by the PEEP, we have already explained to you, recruitment and recruitment, and we are trying to achieve the best compliance, best oxygenation, lowest dead space. Not normal compliance, normal oxygenation, normal carbon dioxide. We are not targeting for that. We are targeting for best. So that is what the optimization is. So as you can see, in optimal PEEP, your PO2s, your delivery of oxygen is the best, your cardiac output is best, and your SCPO2 is low. So this is what the optimization. So it is not just oxygenation, it is other factors. But whether lactates are coming down, your hemodynamics are improving or not. So there are ways. The classical way described in the textbooks is the lower inflection point. So if you see the PV loop, pressure volume loop, so this is the inflection point. Now this lower inflection point, they say to keep your P above lower inflection point, but it does not tell you whether at this level the overinflation is occurring. So now look, first of all, practically it is very difficult to identify lower inflection point at the bedside. I have never been able to do that. So for this the child has to be deeply sedated or paralyzed. You have to give muscle relaxant. And the PEEP set above the lower inflection point tells you about the beginning of recruitment. It doesn't tell you about the end of recruitment. How many alveoli are recruited. So if you keep on increasing the PEEP setting on the PV according to PV loop, then your recruitment will improve. So this is where the opening is occurring. So you can see the optimization. But again I am saying it is not the best method. Practically it is not doable at the bedside. But what we do, this is another way that these are the charts available in everywhere, it's freely available. So these are the charts based on the relationship between the FiO2 and P. So these are the high FiO2 table. This is the low, higher P, low FiO2 table, depending on the level of the PO2 and FiO2. So these are available freely on the net. This is a very important method. If you have ETCO2 monitoring, and then you start increasing your PEEP gradually at the PEEP of 10. So this is the PEEP of 15. So this is the PO2s and this is the PCO2. That is the ETCO2 that you can see on the monitor. So as there is an improvement in the oxygenation, with the increase in PEEP, your ETCO2 will also improve. So but at one level, once you cross that optimal level, your ETCO2 will start rising. So it means you are creating dead space now. It means you are creating dead space. So that is how you can use this SPO2, your saturation is there, your ETCO2 monitor is there, so you can titrate every 5 minutes, you increase your PEEPs and look at the saturation, look at the blood pressure, look at the heart rate and look at the ETCO2, and you can check the compliance whether it is improving on the monitor. So you have to look at the lung on the ventilator screen as well as on your multi-parameter screen. Another, in some machines, there is stress index. I will not go into the details, but again it is based on the pressure volume curve. So whenever there is, the stress index is calculated by the machine, and this is how the rise should be. This is the pressure time scalar, and then the rise should be straight. If there is a concavity downwards or concavity upwards, it is indicating overinflation, it is indicating alveolar collapse. So there are some machines, I think Hamilton has a machine where the stress index is real-time monitoring. You can see it on the screen and you can titrate your PEEP. Ultrasound is available in many units now, so it is another method where you can do the recruitment or the alveolar PEEP titration and look at your lungs. What you see in ARDS, you see B lines, right? You will do ultrasound check lung. B lines, you see pleural thickening, shaggy pleura, and you see some find improvement in the B line, their collates or what you call them rockets will become segregated, discrete. So that is indicator of recruitment. So optimal PEEP is you check the blood pressure, you look at the breath sound, you check the ventilatory parameters, and of course you will see at the PF ratio or SF ratio and PCO2 looking at the, so PCO2, high PCO2 is no contraindication. You can go up to 50, 55 and keep your pH around 2.5 or above 2.5. Recruitment maneuvers, it's basically a process of opening the lungs. So this is called open lung strategy. You give high pressure to the lungs, it opens, and then you titrate your PEEP. Once you have recruited the whole lung, and then you do the titration. But it has gone out of favor because of the complications, because of the high incidence of pneumothorax, barotrauma, and high incidence of hemodynamic instability. So there are, we used to do it, but now we have stopped doing it. This is what I have taken, open the lung and keep it open. So that is what was the concept of recruitment maneuver. You increase your pressure. If your patient is on pressure control ventilation, you increase the pressure to 30 centimeters or 30 seconds or 45 seconds, and then you bring down the PEEP to a level where your compliance and the blood pressures are maintained. So these are different methods. Sustained recruitment by decremental PEEP or incremental PEEP. So these are some of the studies are available, but many of the papers have shown improvement in oxygenation, but no improvement in outcome. That is, no improvement in mortality. So the PALIC 2 says we cannot suggest or against the recruitment maneuver. So it is the individualized decision that they are suggesting. So this is prone ventilation. Very commonly used. We are very comfortable with prone ventilation. Even in 80 kg child, we can do proning now. So there are many papers available. Basically, as I said previously, that ARDS is a disease of dorsal dependent lung. So when you prone the patient, then your dependent lung is up, right? And the distribution of the gases is more towards that. And this is how it is. So this is in inspiration, this is expiration in supine position, this is inspiration in supine position, and this is, you can see, in prone position, the ventilation has improved so beautifully as compared to supine position. So when we are proning the child, we should prone early, not after 4 days. If your patient is not improving in first 6 to 12 hours of your titration and all the maneuvers, you should prone early and prolong proning. 6 hours proning is not going to help you. You should prone at least for 18 hours, out of 24 hours. There are many units who prone for 20 hours now. So prone early and prolong. This decreases the lung parenchymal heterogeneity that I have explained to you, decreases the extreme tissue strain, and prevent ventilator-associated lung injury. So early proning, low tidal volume strategy which we have discussed, and BVFO I will just come to you. This is all improves the mortality. So these are the different contraindications, like patient who has increased intracranial pressure, patients who have facial injuries, patients who have spinal injuries. So we should avoid proning in these patients. But there are different studies have taken different contraindications. But most of the units in patients who are very unstable hemodynamically avoid. So this is the study which showed that the prone positioning improves mortality. This is the survival. This is the probability of survival was much more significantly more in the prone group. Now another modality which is out of the adult ICU, but we are still using and very comfortable with is the high frequency ventilation. How does it work? It provides small tidal volume. We are always scared of the tidal volume in ARDS patients. So we are just providing small tidal volume. We are using higher mean airway pressures, so better alveolar recruitment and better oxygenation. Smaller gradient between inspiratory and expiratory pressures, low peak pressures, so there is less barotrauma and low stretch, that is less biotrauma. So how is this different from the conventional ventilation? in CMA, this is the way that is going, right? So this is the peak pressure, this is your end inspiration and expiration. So look at the difference. In high frequency oscillator, we are giving very small tidal volumes, and the difference between the peak and the end inspiratory and end expiratory pressure is very, very low. So better recruitment. So we are in the better recruitment over here. So map is identical for both ventilation, that is both types of ventilation, but the amplitude which I have explained to you is much different, and it is much smaller in the oscillation than in the conventional ventilation. So it is usually used as a rescue therapy and not as a primary therapy. So when you have done your conventional ventilation and you are not achieving your targets, you think of using high frequency oscillator. And over here I was saying that exhalation is, there is a decoupling of inspiration and expiration. So inspiration is separate setting, expiration is separate setting. So there is a decoupling. The expiration is active in these patients. So oxygenation depends only on two factors: what is the mean airway pressure you have set and what is the FiO2 you are giving. While ventilation, that is the CO2 part, depends on the amplitude that you set of the machine, frequency and the percentage of inspiratory time. So this is how it is. I just want to tell you one thing, that in the conventional ventilator, when we increase the frequency of ventilation, we decrease the carbon dioxide, right? But in high frequency oscillator, it is different. It is reverse. So when you increase the frequency on high frequency ventilator, your CO2 will increase. That is basically you are in lower frequency, the larger volume is displaced. So in lower frequency, larger volume of gases are displayed. So that is why your CO2 will decrease. So this is a very important concept when you are using high frequency oscillator. So clinical goals on high frequency oscillator, saturation is targeted below 92. We are not targeting 95. PO2 is between 55 and 90. Permissive hypercapnia should be there. And cardiac monitoring is very important, especially in patients who have right ventricular dysfunction. So if a patient has right ventricular dysfunction, high frequency is not a good choice to be taken. As I said, PCO2 can rise and keep the watch of the pH. So normal pH, normal CO2, normal PO2 are indicators of overventilation in high frequency oscillator. So you come to conventional ventilator. Transpulmonary pressure. Very briefly, this is a new method of ventilating ARDS patients. So what is transpulmonary pressure? It is the alveolar pressure minus pleural pressure. How do I measure the pleural pressure? Alveolar pressure, plateau pressure, it is the surrogate. The plateau pressure is surrogate of alveolar pressure. Because that is the pressure at the end of flows. So that is surrogate of alveolar pressure. So to measure the pleural pressure, we put in a catheter which has a balloon in the esophagus, in the lower end of the esophagus, and the pressure is recorded there, displayed by the machine. So it tells you how much pressure is there required to inflate the lung and how much pressure is required to inflate the chest. As you can see on this graph, this is the normal lung. The pleural pressure is 5 centimeter. Your inspiratory pressure is 30 centimeter. So your transpulmonary pressure is 25. But if this child has chest wall problem, right? There is chest wall edema, heavy bandages are there, chest wall edema is there, or there is some, especially in dengue patients. In dengue patients, your chest wall edema is so much there, or there is abdominal hypertension. So whenever there is abdominal fluid is there, ascites, tense ascites is there, that will create abdominal pressure, and that pressure will reduce your chest wall compliance. So the chest wall compliance is poor. So the same inspiratory pressure, because the pleural pressure is increased, so your transpulmonary pressure is just 15. So your lung out of 30 is receiving only 15 centimeters of pressure. So that is how the transpulmonary pressure will segregate your lung pressure as well as the chest pressure. So this is the machine that we are using. So you can I'll show you the X-ray. This is the transpulmonary pressure catheter, and this is the catheter in the X-ray. The lower third of the catheter should be behind the heart, and this is how you look at the transpulmonary waveform. So when you check the transpulmonary blood pressure, transpulmonary peak pressure, so you aggregate. So this is our data, which is under consideration for publication. So there is a higher peaks were used when we use the transpulmonary pressure, higher maps were achieved, and dynamic compliance was also better in these patients, and the dead space was lower. So this is the graph which I want to concentrate. So we know about tidal volume, we know about peak, we know about the driving pressure. So this is the graph which will summarize everything. So there are two graphs. One is the red line where the compliance is 14 ml, and this is the graph where the compliance is 35 ml. So this is better compliance graph, this is a poor compliance graph. Over here you can see the driving pressure is also there, respiratory rate is also there, driving pressure is also there, respiratory rate is there. Similarly, driving pressure and two different settings. In a patient who has poor compliance, so this is the odds of death. On the y-axis you can see the odds of death, and this is the tidal volume. So 6 ml is the tidal volume. 6 ml is the tidal volume that we use. Correct? So in a patient who has a poor compliance, if your driving pressure is high of 27 with a respiratory rate of 30, your odds of death are high. Over here, when you control the driving pressure to 20, 21, and the respiratory rate is high, the odds are still high, 2.2. But in the child who had a good compliance of 35, even then, if your driving respiratory rates are 40, which is unphysiological, then your odds are high. So we should keep driving pressure, respiratory rate also very important. Many of the units, there is no consideration of respiratory rate. But just imagine 20 rate, 40 rate, the alveoli opening, closing 20 times, opening, closing 40 times. So how much is the strain on the lungs? So now there is a concept of mechanical power. All the factors, peak respiratory pressure, tidal volume, peak, respiratory rate, driving pressure, everything has been collated into a concept of called mechanical power. So whenever we are putting a patient of ARDS on ventilator, we should keep every parameter into account and do not ignore any parameter. Now, small bit about the VV ECMO. This is the child who is on VV ECMO, came from Ludhiana only. So indications, whenever you are unable to maintain the patient on conventional or high frequency, so very poor PF ratios, very high OI, and this is a reversible respiratory failure. That is the most important indication. And these are the different diseases where we can use it. So when we are using VV ECMO, it means we are draining blood from the venous axis and we are pushing the fat, returning into the vein. So the patient's native heart is functional. When we use VA ECMO means we are draining from the vein and putting into the arterial system. So over here we are bypassing the patient heart. So VA ECMO is indicated when there is a primary cardiac problem. And VV ECMO we are using in patients with the primary respiratory problem. But if the patient is on some inotropes because of the ARDS, because of the hypoxia the child has suffered, in these patients also we should give VV ECMO because VV ECMO is technically much easier than the VA ECMO. So this is what I am saying. VV ECMO, you are draining from one side, you are pushing it into the city. From the IJ you are draining out and you are returning into the femoral artery vein. Oxygenated blood, that is why it is in red. And VA ECMO, you are draining from the vein IJ and pushing it back into the femoral artery. In pediatric patients, in small kids, we usually don't use femoral arteries or femoral vessels, we use IJ or carotids. So this is the X-ray of patient who is on VA ECMO. So this is the venous, this is the artery, this is the aorta, and this is in the superior vena cava. So this contaminate the blood, return in this, and it will go into the tricuspid valve, through the tricuspid valve into the right side, in the right ventricle, and it will be pushed by the patient heart. So outcome are good in patients who have viral pneumonias, aspiration pneumonias, then bacterial pneumonias. But patients who have sepsis, this is the 40% is the outcome means survival, mortality, or 40% fungal infections. All these are outcome are not good. Non-ventilated management, very briefly, all these patients require sedation, they need analgesia or plus minus relaxants. So mostly in first 2 to 3 days, which is a very dynamic situation, we give intermittent muscle relaxants. Hemodynamic management, you have to maintain blood pressures, you have to optimize the cardiac output. Antibiotics, early antibiotics, because in our setup, infections are the commonest causes. Always give conservative fluids. Don't give liberal fluids to these patients, because if your fluid accumulation is too much, there is a fluid overload state, then the outcome is not good. The mortality is there. So we always try to maintain negative fluid balance in these patients. Restricted blood and blood component use. You need to maintain hemoglobin of 8 or more than 8. In some centers, even in severe ARDS, it is 7 or more than 7. So we are not targeting hemoglobin. Oh, this child is in ARDS, his PO2 is very low. No, that is not the criteria. So do not use liberal blood or blood components. Steroids till this time, no recommendation from PALIC 2. But in special situations like during COVID time, steroids showed mortality benefits. So in such situations, you may use early feeding. ARDS is a single organ disease. If you do not feed them and do not maintain their hemodynamics and all, so there is a chances of ischemic injury in the other organs. So your patient will move from one organ failure to multi-organ failure. So early feeding will prevent the translocation of bacteria from the gut to the circulation. So early feeding, enteral feeding, not parenteral feeding, and meticulous nursing care. Train your nurses on regular basis. Keep on checking their monitoring charts, and it is very essential. This is not a job of single person to manage case of severe ARDS. So we need to monitor multi-parameter monitors. We need to monitor lung mechanics. That is, we need to look at the lung graphics, blood gas analysis, and of course, bedside ultrasound is a very useful tool in these patients. So this is just to summarize. You have a patient of hypoxemic ARDS, PO2s are low, saturations are low, you titrate the peak, you have already touched 12, the patient is still hypoxemic, you think of alternative strategy. Should I go to HFO? Should I go to do recruitment maneuver? Should I think of VV ECMO? And this is again, whatever I have told you, all those concepts are there. And this is what is the best statement by the PALIC 2. This is taken from the PALIC 2. So conclusion, ARDS is a complex and dynamic clinical entity. Identification and stratifications of the patient are extremely important to set the treatment priorities. Mechanical ventilation is the mainstay of treatment to buy time. Mechanical ventilation is not going to cure the pneumonia. Mechanical ventilation is only buying time. So your other treatment, antibiotics, antivirals, all those are going to treat the pneumonia. Non-pulmonary management should not be ignored. Please do not harm the patient by achieving normal targets. No. Early and timely referral to the higher center once you are done with your titration and you don't have high frequency oscillator and some other unit has so try to transfer the patient. And that now the very good transport teams are available, especially in the metros. So timely and early transfer to the higher centers may save the life. Thank you very much. I have overstepped my existing, but I can tell you that this is just a bird's eye view of the ARDS management.
Any questions?
Want to have advantage of my knowledge, sir. In COVID, we know it was a disease of inflammation and thrombosis, and we had better outcomes with HFNC rather than IVR.
They are better outcome. Yes, that is what it is. Proning, we took the advantage, physiological advantage of proning along with hypronasal canal. Because hypronasal canal, heated air, gases were there, so there was better
It was
distribution.
generating better flows, but the pressures were not giving us any.
Yes, yes. But by proning, we changed the physiology. Yes.
Thank you. Thank you.
Pneumonia cases, which mode should be preferred? CPAP or BiPAP?
Sorry?
Pneumonia cases, which mode should be?
BiPAP.
Can we use CPAP in newborns if BiPAP is not available?
Yes, but most of the machines will give you both. Most of the machines will have BiPAP and CPAP.
It was actually a vast ARDS, covering ARDS.
And one, like in this short talk. Thank you, sir. Thank you so much. And I call upon Dr. Harinder Singh. He's a very senior pediatrician, and sir, to give the way to token. Sir.
For IP President election in 2025, sir.
I also called to support him as a first man who is contesting election from Punjab. Thank you, sir. Thank you very much for the lightning talk. Sir took 4 o'clock flight.
Sir took 4 o'clock flight from Delhi. He went to airport. The flight got cancelled. He waited there, took 8 o'clock flight to Amritsar and then reached Ludhiana. And now by 4 o'clock again, he will be traveling to Chandigarh to catch a flight back to Delhi.
This is the commitment we have seen as a student. कभी I think 1% भी पहुंच गए तो बहुत बड़ी बात होगी. Thank you, sir.
Now we have a small sponsored session from GSK, who has sponsored this evening today. It's just a 5-minute talk on our normal, common bread and butter, that is vaccination in pediatrics. The lunch is, so we will. So one is the slides on our So one question about this is, are all acellular vaccines are same? I just want to know from the audience, what is your opinion on that? Are all acellular vaccines are the same? Do you find any difference? Any clue about it? Are we using, there are 2-3 vaccines available, 2 vaccines mainly, one is in pandemic sector, another one is from the Sanofi. Are both the same, efficacy wise? But yes, there are certain other issues like this vaccine, they are using more antigens, and that's why the immune response with this influenza hexa is a bit better. But because the immune response is a bit better, then when we talk about the immune response, there are 2 common things. If you need 40% immunity to 40% antibody titers to against any disease, this vaccine will give you, one will give you 80%, 88%, one will give you 92%. Only this is the difference, while only you need 40%. So another question is, we have been asked, or we have been informed that the wholesale vaccines are better than acellular vaccines. So what is your take on that?
From Pertus's point of view, that is
Immunogenicity of wholesale is low.
So then, sir, why all the other developed countries are not changing to wholesale again back?
But then that is why they are suffering from Pertus's outbreaks and.
But then don't we are suffering from Pertus's outbreaks?
Because I understand, but there could be a large gap in the vaccination coverage in our country also.
It's not. It's now the concept is clear. Pertus's vaccine is not till 5 years. You have to repeatedly take it. That's why in pregnancy also the tetanus dose has been replaced with Tdap. Nowadays, tetanus doses are replaced. If you will try to find the literature on single tetanus toxoid doses, what is their schedule, you will not find it anywhere now. It's all Tdap. So it has been said that acellular pertussis vaccine has to be taken again and again. Like we have started using till 10 years. Tdap is now given till 10 years. But in all other countries, it's an adolescent vaccine schedule, adult vaccine schedule, where they're using it again and again. So the outbreak is not because of decreased efficacy of the vaccine, acellular vaccine. It's because initially the data was not there. Now it has been recognized that this vaccine needs, you have to take this vaccine almost every 5 to 10 years again and again.
In US, the newborn caretaker is supposed to take Tdap.
Yes.
Not only the mother.
Yes.
Not only the mother, the grandmother, dadi
Yes.
or nani, who is taking care of the newborn,
Yes.
is supposed to have Tdap.
Yes. And also, even the child got injury and it's a dirty wound and where you need to give tetanus toxoid is no longer available now. In all other Western countries, it's always Tdap. Right? In hospital vaccination schedules, like we are monitoring hepatitis B, we are monitoring chickenpox varicella vaccination. Even for tetanus schedule also, it's all Tdap. No tetanus toxoid alone is available. So, this is all about various other components. What I want to summarize about this is that acellular vaccine has an important role. And acellular vaccines, as compared to cellular vaccines, it has some less immune response. But then if you need, what are the antibody titers which are available, then they are quite well against the lower level which is available. Yes, immunity, the lasting of immunity by single dose of cellular vaccine and cellular vaccine is a difference. That immunity is a bit longer lasting. But if you are taking regular scheduled doses of cellular vaccine also, then it hardly makes any difference. And yes, even after taking cellular vaccines also, wholesale vaccine, it doesn't mean that you don't have to take regular pertussis vaccines again. It has now, the data has come up, people have started monitoring it and they have shown that even the immunity with the wholesale vaccine also wanes after some time. So, now this is a comparison study that which vaccine is better. This is 3-component vaccine, the other one is 2-component vaccine. That's why milder some side effects are more common with this, that you will local reaction fever is a bit there. But as per some studies that the comparison data what they have provided, there is this overall antibody titer is more with the inflammatory effects are low. So efficacy is good, no doubt about it, but you have to explain to the patient that yes, some amount of fever can come. So what I do is that I tell them that any vaccine can give you a fever, but this is the one which is acellular one, and this is the cost, other one, and this is also acellular one, and that's the cost. It's their choice what they want to give. So otherwise it's a safe vaccine. We don't find any major concerns with the vaccine, no major side effects as compared to only the comfort of the baby is concerned. And overall, this is a widely accepted vaccine because it's cost effective. Cost is quite, when the patient is spending high, even to the highest family also, if you give both the options, they will choose which one is cheaper one. So, and overall side effects are not much. So, this is about all about small other session about this is hepatitis A vaccine. So hepatitis A vaccination, like since we were studying, this vaccine is in place, and initially I think this Habits was the only one which was there, and now some other companies have also come up with the hepatitis A vaccination in India. So one thing I want to ask about hepatitis A is, supposedly the child gets a 1 dose of hepatitis A and he misses another dose. And even after 6 months, maybe after 2 years, he comes back to you and he gives you the card that, yeah, I have got only one vaccine. So after 2 years, what should be the schedule of whether he should get the first dose again or whether the another dose is sufficient?
Second dose.
Second dose is? Sufficient, yes. So this is true with almost all the vaccines. So if there is an incomplete vaccination and the child has missed the second dose and the child has come back to you after 2-3 years and saying you that maybe they forgot to take it and now they have come back again when they saw the card that this vaccine was missed. So you have to give second dose, its first dose is not required again. Yeah? Yeah, influenza vaccination is only first doses are required 2 doses, otherwise it's only 1 dose in a year. So if it has missed 1 dose, even if true is, this is true with the HPV vaccination also. So if the HPV vaccination, if the patient is taking only 1 vaccine and the second dose is missed or even the, you are following 3 dose schedule in a child who is adolescent more than 14 years of age, if the child has missed 1 dose, then you start from the same dose only. It's not like you have to give first dose again. So, what about efficacy of vaccine? Is there anybody have any doubt about hepatitis A vaccine? Because it's a very effective vaccine, and I think this vaccine, now the government of India is trying to introduce the typhoid vaccination in our universal immunization program. But I think this vaccine should come first to universal immunization program rather than typhoid. Because typhoid is a disease which is commonly managed on OPD basis and hardly we see any mortality associated with typhoid. But hepatitis A, in our ICUs, every year we see 4-5 patients coming to us permanent hepatitis and poor setup because they have not exposed to good food hygiene. They drink water from elderly stores and then they catch up this hepatitis A infection because they have not been immunized with it. And the child comes with you with pulmonary hepatic failure and the child is in hepatic encephalopathy and on ventilator, and you even tell them about transplant also, but the family doesn't afford transplant. And many a time, every year, 5-6 patients you lose because of hepatitis A. So if you see the mortality associated with this disease, percentage-wise it's very less because it's largely subclinical infection. Even the clinical infections are very mild and managed on OPD basis. Hardly few patients require hospitalization. But this vaccine should be introduced in the universal immunization program because it's a more deadly disease as compared to typhoid. I checked this data a few years back. I don't know what the recent latest status is, but the live vaccine was a Chinese vaccine which was introduced in China. And after initial workup, the Chinese government also found that this single dose is not effective. They withdraw the vaccine from Chinese market. It was then again introduced with some minor changes, and now it's still available there. The live vaccine is a Chinese vaccine. It's produced only in China and it's coming from China only. So the papers initially which came up, they showed that it's a subclinical response, and the response was not protective enough to prevent you from a infection. If you get a very high dose of infection initially, supposedly the inoculate dose is very high, then probably the vaccine was not used, and it was seen that after 3-4 years of even the immunity of the vaccine started waning. So, but then again after 2-3 years it was introduced again in the Chinese market, and again it has become available in Indian market. So I don't know what the changes they have done and why the vaccines again, because now the company flow coming to us, they are showing that it's a comparable immunity. But I myself am not using live vaccine, I am using only field vaccine 2 doses. So we tend to get hepatitis A epidemic every year. Now these are the months where we get epidemic, and we see a lot of patients of hepatitis A because it's a waterborne disease, and in rainy season there is sewage mixing occurs with the drinking water, and then this happens. So the commonest way of what we should advise our family that how to prevent hepatitis A. The hepatitis A prevention is, first is don't eat golgappas. So golgappas are typhoid and hepatitis A bombs basically. They are made from the water probably which is never clean. It's a normal tap water we are using. Don't use chutneys. So if some family has to eat outside, always tell them to eat cooked food. Don't take paraphernalia along with what is available. Take fat ketchup packets rather than eating the fully chutneys, green ones and the imli chutneys and the golgappa. So any questions about hepatitis A?
So what if a child has never get immunized with hepatitis A and a 9 to 10 years old child has got the infection? So any role of vaccination?
No. If the child has got natural infection, there is no role of any vaccination. If it's a proven, the IgM hepatitis is actually IgM is positive, then there is no role of vaccination. And even like if the child has come to you at 10 years of age and they have never got any vaccine and they want to give you a vaccine, most of the time these children are exposed to subclinical infection. They might be immune to. If you get the IgG, HIV, hepatitis A virus status, they might be positive. Because 90% of the hepatitis A infection is subclinical infection. That's why probably the government is not using this vaccine universal immunization.
The child is suffered from hepatitis A. Should he be vaccinated?
No, no need.
No need to repeat. Like
But you should prove it that it was hepatitis A only. It was either IgM hepatitis A should be positive.
And of course, that is not true for typhoid.
No.
That has to be vaccinated.
Yes. And the reason is that you need very high antibody titer to prevent from typhoid infection. And inoculum of typhoid, salmonella typhi, is very high when you get exposed to the unhygienic environment, particularly unhygienic food. So many times inoculum is so high that it will not protect you against it. That's why even conjugated typhoid vaccine for patients, they have a breakthrough that you will get they will have positive salmonella typhi cultures also, because if the inoculum load is very high, then the vaccine becomes ineffective. Yes.
I just want to share that this year, in the last 2 months, we had very bad entry. Very bad entry. Adolescents with myocarditis, multi-organ failure, intestinal perforation. We had 4 cases in the last 2 months. And regarding hepatitis A, if encephalopathy, then early use of CRT or plasmapheresis, it can prevent the transplantation. And if the patient is very sick, always think of hepatitis A with Wilson's, autoimmune, like combination. In India, the combinations are very common. So if the patient is not improving, then think of Wilson's, think of autoimmune hepatitis along with hepatitis A.
That the vaccine is not very, we have a patient with 8% ejection fraction, 12 years old, collapsed in the unit and needed ECMO. Fortunately, he was discharged, but blood culture was normal times. Bad myocarditis.
Bad myocarditis. We have 4 cases.
So any more questions? I think we'll wind up the session and we will disperse for the lunch. It's a short lunch because we are going late. Within half an hour we'll be again, we'll be sitting in the hall and we'll have a panel discussion. Thank you very much and enjoy your lunch.
बैठे हुए बड़े सवाल पूछ रहे हैं। हाँ जी, हाँ तो वो तो करनी है, वो तो करनी है, वो तो करनी है। हमने तो सब कुछ करना है भाई। और कैसे हो? अमीर हो ना, आपको पहले दिन लोग मिलते रहते हैं।
वही आते हैं
total transformation. And it's a total transformation. Maybe, yeah. Shortcake, strawberry shortcake. Sort for skins. Fine, shortcake. And one station will be by that. She made changes.
पॉज नहीं होगी,
It'll keep going.
क्या बंद होगी? 0 व्यूअर्स बंद ही कर देते हैं।
बंद ही कर, मैम से पूछ ले, मैंने